Okay. 1265 to 1270 gastritis. Although only a few diseases affect the stomach, they can be very serious and in some cases life-threatening. The most common disorders include gastritis, peptic ulcer disease, and gastric cancer. Each of these health problems can result in impaired or altered digestion and nutrition. The stomach is part of the upper GI system that is responsible for a large part of the digestive processes. Collaborative management of patients with stomach disorders often includes therapies to meet the human need for nutrition. Gastritis. Gastritis is the inflammation of gastric mucosa, stomach lining. It can be scattered or localized and can be classified according to cause, cellular changes, or distribution of the lesions. Gastritis can be erosive, meaning causing ulcers, or non-erosive. Although the mucosal changes that result from acute gastritis typically heal after several months, this is not true for chronic gastritis. Pathophysiology. Prostaglandins provide a protective mucosal barrier that prevents the stomach from digesting itself by a process called acid autodigestion. If there is a break in the protective barrier, mucosal injury occurs. The resulting injury is worsened by histamine release and vagus nerve stimulation. Hydrochloric acid can then diffuse back into the mucosa and injure small vessels. This back diffusion causes edema, hemorrhage, and erosion of the stomach's lining. The pathologic changes of gastritis include vascular congestion, edema, acute inflammatory cell infiltration, and degenerative changes in the superficial epithelium of the stomach lining. Types of gastritis. Inflammation of the gastric mucosa or submucosa after exposure to local irritants or other cause can result in acute gastritis. The early pathologic manifestations of gastritis is a thickened, reddened mucous membrane with prominent rugae or folds. Various degrees of mucosal necrosis and inflammatory reaction occur in acute disease. The diagnosis cannot be based solely on clinical symptoms. Complete regeneration and healing usually occur within a few days. If the stomach muscle is not involved, complete recovery usually occurs with no residual evidence of gastric inflammatory reaction. If the muscle is affected, hemorrhage may occur during an episode of acute gastritis. Chronic gastritis appears as a patchy, diffuse, or spread out inflammation of the mucosal lining of the stomach. As the disease progresses, the walls and lining of the stomach thin and atrophy. With progressive gastritis atrophy from chronic mucosal injury, the function of the parietal or acid-secreting cells decreases and the source of intrinsic factor is lost. The intrinsic factor is critical for absorption of vitamin B12. When body stores of vitamin B12 are eventually depleted, pernicious anemia results. The amount and concentration of acid in stomach secretions gradually decrease until the secretions consist of only mucus and water. Chronic gastritis is associated with an increased risk for gastric cancer. The persistent inflammation extends deep into the mucosa, causing destruction of the gastric glands and cellular changes. Chronic gastritis may be categorized as type A, type B, or atrophic. Type A, or non-erosive chronic gastritis, refers to an inflammation of the glands as well as the fundus and body of the stomach. Type B chronic gastritis usually affects the glands of the antrum, but may involve the entire stomach. In atrophic chronic gastritis, diffuse inflammation and destruction of deeply located glands accompany the condition. Chronic atrophic gastritis affects all layers of the stomach, thus decreasing the number of cells. The muscle thickens and inflammation is present. Chronic atrophic gastritis is characterized by total loss of fundal glands, minimal inflammation, thinning of the gastric mucosa, and intestinal metaplasia, or abnormal tissue development. These cellular changes can lead to peptic ulcer disease, PUD, and gastric cancer. Etiology and genetic risk. Acute gastritis. The onset of infection with Helicobacter pylori can result in acute gastritis. H. pylori is a gram-negative spiral-shaped bacterium that penetrates the mucosal gel layer of the gastric epithelium. Although it is uncommon, other forms of bacterial gastritis from organisms such as Staphylococci, Streptococci, E. coli, or Salmonella can cause life-threatening problems such as sepsis and extensive tissue necrosis or death. Other infectious causes of acute gastritis can be found in patients with immunosuppressive disorders. In those with acquired immune deficiency syndrome, or AIDS, for example, gastric erosions may be present with herpes simplex and cytomegalovirus, or CMV, infection. Long-term NSAID use creates a high risk for acute gastritis. NSAIDs inhibit prostaglandin production in the mucosal barrier. Other risk factors include alcohol, caffeine, and corticosteroids. Acute gastritis is also caused by local irritation from radiation therapy and accidental or intentional ingestion of corrosive substances, including acids or alkalis, e.g. lye and drain cleaners. Emotional stress and acute anxiety may also cause gastritis. Chronic gastritis. Type A gastritis has been associated with the presence of antibodies to parietal cells and an intrinsic factor. Therefore, an autoimmune cause for this type of gastritis is likely. Parietal cell antibodies have been found in most patients with pernicious anemia and in more than one-half of those with type A gastritis. A genetic link to this disease with an autosomal dominant pattern of inheritance has been found in relatives of patients with pernicious anemia. The most common form of the disease is of gastritis is type B gastritis, caused by H. pylori infection. A direct correlation exists between the number of organisms and the degree of cellular abnormality present. The host response to the H. pylori infection is activation of lymphocytes and neutrophils, release of inflammatory cytokines such as interleukin or IL-1 and IL-8, and tumor necrosis factor, or called TNF alpha. Damage to mucosa. All those they release inflammatory cytokines, the IL-1, IL-8, necrosis, the TNF alpha, and they all damage the gastric mucosa. Okay. Chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking have been linked to chronic gastritis. Surgical procedures that involve the pyloric sphincter, such as pyloroplasty, can lead to gastritis by causing reflux of alkaline secretions into the stomach. Other systemic disorders. Oh, okay, sorry. Cat knocked over a garbage can. Okay. Chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking have been linked to chronic gastritis. Surgical procedures that involve the pyloric sphincter, such as a pyloroplasty, can lead to gastritis by causing reflux of alkaline secretions into the stomach. Other systemic disorders such as Crohn's disease, graft versus host disease, and uremia can also precipitate the development of chronic gastritis. Atrophic gastritis is a type of chronic gastritis that is seen most often in older adults. It can occur after exposure to toxic substances in the workplace, e.g. benzene, lead, nickel, or H. pylori infection, or it can be related to autoimmune factors. Health promotion and maintenance. Gastritis is a very common health problem in the United States, yet a balanced diet, regular exercise, and stress-reducing techniques can help prevent it. A balanced diet includes following the recommendations of the U.S. Department of Agriculture and limiting intake of foods and spices that can cause gastric distress, such as caffeine, chocolate, mustard, pepper, and other strong or hot spices. Alcohol and tobacco consumption should also be avoided. Regular exercise maintains peristalsis, which helps prevent gastric contents from irritating the gastric mucosa. Stress reduction techniques can include aerobic exercise, meditation, reading, and/or yoga, depending on individual preferences. Psychotherapy may also be considered. Chart 58.1, Patient and Family Education Guide. Gastritis prevention. Eat a well-balanced diet. Avoid drinking excessive amounts of alcoholic beverages. Use caution in taking large doses of aspirin, other NSAIDs, e.g. ibuprofen and corticosteroids. Avoid excessive intake of caffeine-containing beverages, especially coffee and tea. Be sure that food and water are safe to avoid contamination. Manage stress levels using complementary and alternative therapies such as relaxation and meditation techniques. Stop smoking. Protect yourself against exposure to toxic substances in the workplace such as lead and nickel, and seek medical treatment if you are experiencing symptoms of esophageal reflux. Excessive use of aspirin and other NSAIDs should also be avoided if a family member has H. pylori infection or has had it in the past. Patient testing should be considered. This test can diagnose the bacteria before they cause gastritis. Patient-centered collaborative care assessment. Physical assessment, clinical manifestations. Symptoms of acute gastritis range from mild to severe. The patient may report epigastric discomfort, anorexia, cramping, nausea, and vomiting. Chart 58.2. Assess for abdominal tenderness and bloating, hematemesis. I thought that was hematopsis. Hematemesis, or vomiting blood, or melena, traces of blood in the stool. Symptoms last only a few hours or days and vary with the cause. Aspirin NSAID-related gastritis may result in dyspepsia or heartburn. Gastritis or food poisoning caused by endotoxins such as staphylococcal endotoxin has an abrupt onset. Severe nausea and vomiting often occur within 5 hours of ingestion of the contaminated food. In some cases, gastric hemorrhage is the presenting symptom, which is a life-threatening emergency. Chronic gastritis causes few symptoms unless ulceration occurs. Patients may report nausea, vomiting, or upper abdominal discomfort. Periodic epigastric pain may occur after a meal. Some patients have anorexia. See chart 58.2. Laboratory assessment. Several tests are available to detect H. pylori if gastritis or an ulcer is suspected. One of the most common methods is a blood test to detect IgG, that's I little g big G, or I little gm, IgM anti-H. pylori antibodies. The IgG antibodies become elevated 2 months after infection and stay elevated until over a year after treatment. The IgM antibodies become elevated 3 to 4 weeks after the infection and disappear 3 months after treatment. Another blood test that can be performed in a healthcare provider's office by a finger stick is immune testing using an enzyme-linked immunosorbent assay, or ELISA, and immune chromatography, or an IMC. Chart 58.2, key features: gastritis, acute gastritis, rapid onset of epigastric pain or discomfort, nausea and vomiting, hematemesis, vomiting blood, gastric hemorrhage, dyspepsia, heartburn, and anorexia. Chronic gastritis, vague report of epigastric pain that is relieved by food, anorexia, nausea or vomiting, intolerance of fatty and spicy foods, and pernicious anemia. Other non-invasive ways to test for H. pylori include breath and stool analysis. The C13 urea breath test is very accurate and can be used in a healthcare provider's office or other ambulatory care setting. After being NPO since midnight, the patient drinks a radioactive carbon urea solution. If H. pylori are present, they break down urea to carbon dioxide, which is then eliminated by the lungs. The patient's expired air is measured for the amount of carbon dioxide to determine the presence of the bacteria. Stool testing, HPSA, is done less commonly because the bacteria do not survive in stool. However, ELISA testing can detect the H. pylori antigen in a fresh stool sample. Other diagnostic assessment. An esophagogastroduodenoscopy, EGD, via an endoscope with biopsy is the gold standard for diagnosing gastritis. The physician takes a biopsy to establish a definitive diagnosis of the type of gastritis. If lesions are patchy and diffuse, biopsy of several suspicious areas may be necessary to avoid misdiagnosis. So if the lesions are patchy or diffuse, then a biopsy of several suspicious areas may be necessary to avoid misdiagnosis. A cytologic examination of the biopsy specimen is performed to confirm or rule out gastric cancer. Tissue samples can also be taken to detect H. pylori using rapid urese testing. As the name implies, this test provides quick urese testing. As the name implies, this test provides quick results, unlike the more traditional tissue culture that takes several weeks to determine if the bacteria are present. The results of these tests are not reliable if the patient has not discontinued his or her medications for gastritis, including antacids, for at least 1 week. Common nursing diagnoses and collaborative problems. Nursing diagnoses and collaborative problems that may apply to patients with gastritis include acute pain or chronic pain related to physical injury or inflammation, nausea and or vomiting related to gastric irritation, deficient knowledge related to unfamiliarity with information resources, potential for hemorrhage or perforation. Interventions. Patients with gastritis are not often seen in the acute care setting unless they have an exacerbation or flare-up of acute or chronic gastritis that results in fluid and electrolyte imbalance or bleeding. Collaborative care is directed towards supportive care for relieving the symptoms and removing or reducing the cause of discomfort. Acute gastritis is treated symptomatically and supportively because the healing process is spontaneous, usually occurring within a few days. When the cause is removed, pain and discomfort usually subside. If bleeding is severe, a blood transfusion may be necessary. Fluid replacement is prescribed for patients with severe fluid loss. Surgery such as partial gastrectomy, pyloroplasty, or vagotomy may be needed for patients with major bleeding or ulceration. Treatment of chronic gastritis varies with the cause. The approach to management includes the elimination of causative agents, treatment of any underlying disease, e.g. uremia, Crohn's disease, avoidance of toxic substances, e.g. alcohol, tobacco, and health teaching. Non-surgical management. Eliminating the causative factors, such as H. pylori infection, if present, is the primary treatment approach. Drugs and nutritional therapy are also used. In the acute phase, the healthcare team also provides interventions to relieve pain and discomfort. Drugs that block and buffer gastric acid secretions to relieve pain are usually prescribed. H2 receptor antagonists. H2 receptor antagonists such as ranitidine or Zantac, famotidine or Pepcid, and nizatidine acid are typically used to block gastric secretions. Sulcrafate or carafate or sulcrate, a mucosal barrier fortifier, may also be prescribed. Antacids used as buffering agents include aluminum hydroxide combined with magnesium hydroxide, or that'd be Malox, and aluminum hydroxide combined with simethicone and magnesium hydroxide would be Mylanta. Anti-secretory agents, proton pump inhibitors, PPIs, such as omeprazole or Prilosec or esomeprazole, may also be used to suppress gastric acid secretion. Chart 58.3. Teach the patient to monitor for symptom relief and side effects of these drugs, and to notify the healthcare provider of any adverse effects or worsening of gastric distress. The dose, frequency, or type of drug may need to be changed if symptoms of gastric irritation appear to persist. Teach patients not to take additional over-the-counter or OTC drugs such as Pepcid AC if they are taking similar prescribed drugs. Patients with chronic gastritis may require B12 for prevention or treatment of pernicious anemia. If H. pylori are found, the healthcare provider treats the infection. Current practice for infection treatment is described on page, doesn't tell me, in the discussion of drug therapy in the peptic ulcer disease section. The nurse, healthcare provider, or pharmacist teaches patients to avoid drugs and other irritants that are associated with gastritis episodes. These drugs include chemotherapeutic agents, corticosteroids, erythromycin or emycin, erythromid, and NSAIDs such as aspirin, naproxen or naproxen, and ibuprofen, Motrin, Advil, Amersol, Novoprofen. NSAIDs are also available as OTC drugs and should not be used. Teach patients to read all OTC drug labels because many preparations contain aspirin or other NSAID. Additional information about these drugs can be found on page 1274 in the discussion of drug therapy in the peptic ulcer disease section. Instruct the patient to limit intake of any foods and spices that cause distress, such as those that contain caffeine or high acid content, e.g. tomato products, citrus juices, or those that are heavily seasoned with strong or hot spices. Bell peppers and onions are also commonly irritating foods. Most people seem to progress better with a bland, non-spicy diet and smaller, more frequent meals. Alcohol and tobacco should also be avoided. Really? Chart 58.3. Common examples of drug therapy. Peptic ulcer disease. Drug usual dosage. First we got the antacids, which we have magnesium hydroxide with aluminum hydroxide, or Malox and Mylanta, usually 50 to 80 milli-EQ, 1 hour and 3 hours after meal and at bedtime. Purpose of the drug is to increase pH of gastric contents by deactivating pepsin. Nursing intervention would be give 2 hours after meal and at bedtime. Use liquid rather than tablets. Do not give other drugs within 1 to 2 hours of antacids. Assess patient for history of renal disease. And rationale would be hydrogen ion load is higher after ingestion of food. So that's the rationale for 2 hours after. Suspension Suspensions are more effective than chewable tablets for the liquid part. Antacids interfere with absorption of other drugs, and hypermagnesium may result. Also, these antacids have a high sodium content. These antacids contain magnesium, which cannot be excreted by poorly functioning kidneys, thus causing ototoxicity. And that would be you should assess the patient for a history of heart failure and observe the patient for side effects of diarrhea. That would be associated with the magnesium causing diarrhea. Okay. Then there's aluminum hydroxide or Amphigel, 50 to 80 ml/Q, 1 hour to 3 hours after meals and at bedtime, same as the other. Give 1 hour after meals at bedtime. And at bedtime, hydrogen ion load is higher after ingestion of food. Use liquid rather than tablets. Suspensions are more effective than chewables. Do not give other drugs with antacids, blah, 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 same thing. Mess with the absorption. Observe patients for side effects of constipation. If constipation occurs, consider alternating with magnesium antacid. That would be aluminum causes constipation, and magnesium has a laxative effect. And used with patients with renal failure, or used for patients with renal failure. Aluminum binds with phosphates in the GI tract. This antacid does not contain magnesium, so you want to use the Amphigel for people with renal problems instead of the magnesium-based ones. Okay, H2 antagonists. Ranitidine, I can never say this. Zantac, 150 milligrams orally twice daily, or 300 milligrams orally at bedtime. 50 milligrams IV every 6 hours, or 8 milligrams per hour IV continuous. The H2 antagonist decreases gastric acid secretions by blocking histamine receptors in parietal cells. You give a single dose at bedtime for treatment of GI ulcers. No IV ranitidine may also be given to prevent surgical stress ulcers. Bedtime administration suppresses nocturnal acid production. Famotidine or Pepsid, 40 milligrams orally once daily, or in 2 divided doses, 20 milligrams, IV every 12 hours. Note, IV famotidine or Pepsid may also be given to prevent surgical stress and ulcers. Okay, nizatidine or Axid would be 150 milligrams orally twice daily, or 300 milligrams at bedtime. Same stuff. Mucosal barrier fortifiers. Sulcrafate or carafate or sulcrate. So these are mucosal barrier fortifiers, and that's 1 gram orally 4 times daily, or 2 grams twice daily. And it binds with bile acids and pepsin to protect stomach mucosa. Give 1 hour before and 2 hours after meals and at bedtime. Food may interfere with drugs' adherence to mucosa. Do not give within 30 minutes of giving antacids or other drugs. Antacids may interfere with effect. Okay, and proton pump inhibitors. Omeprazole or Prilosec. Losec, 20 milligrams orally twice daily, or 40 milligrams at bedtime. Used to suppress H and K ATPase enzyme system of gastric acid secretion. Used to suppress HK ATPase, HCATPase or HKATPase, whatever, enzyme system of gastric acid secretion. Have patients take capsule whole, do not crush. Delayed release capsules allow absorption after granules leave the stomach. Give single dose at bedtime for ulcer and disease. Bedtime administration suppresses nocturnal acid production. And then lansoprazole or Prefazid, 15 to 30 milligrams orally at bedtime. Give single dose at bedtime for ulcer disease. Do not crush, because administration suppresses nocturnal acid production. Oh wait, no. Take after morning meals. Do not crush capsule. Just said that. Drug is a sustained release capsule Drug promotes healing and symptom relief of duodenal ulcers. Then there's okay, well that, never mind. Med alert, do not confuse Asifex, that's the last one of the Prazols. Asifex 20 milligrams orally once daily, take after morning meal. That's the one you take after morning meal, not the other one. And do not crush capsule. Okay. And then Med alert, do not confuse Asifex with Aricept. There's another one. Protonix, pantoprazole, or Protonix, 40 milligrams orally or IV daily for 7 to 10 days. Do not crush. Drug is enteric coated, whatever that means. Inner coated. IV form must be given with filter and in a separate line for Protonix. Do not give Protonix IV with other IV drugs. Given IV drug precipitates easily, or given IV, the drug precipitates easily. The IV form is not compatible with most other drugs. Okay, there's another one. Esomeprazole or Nexium, 20 to 40 milligrams orally or daily, or IV daily for 7 to 10 days. Give 1 hour before meals. Assess for hepatic impairment. Do not give Nexium IV with other IV drugs. Food decreases absorption. Patients with severe hepatic problems need a low dose, and the IV form is not compatible with most other drugs. Then there's the prostaglandin analogs, and that would be misoprostol or Cytotec, 200 micrograms orally 4 times daily, used to decrease gastric secretions and enhance resistance to mucosal injury when patient is taking NSAIDs. So it decreases gastric secretions and enhances resistance to mucosal injury when taking NSAIDs. Take with food. Drug protects against NSAID-induced ulcers. Avoid magnesium-containing antacids. Both misoprostol and magnesium-containing antacids can cause diarrhea because of the magnesium. And there's the antimicrobials. Clarithromycin, clarithromycin, or Biazin, 500 milligrams orally 3 times daily. Used to treat H. pylori. Antimicrobials should be given as part of therapy to eradicate H. pylori infection. H. pylori is a gram-negative bacterium implicated in the development of peptic ulcer disease, or PUD. And then the other ones they give for H. pylori are amoxicillin, Amoxil, 1 gram orally twice daily, tetracycline, 500 milligrams orally 4 times daily, and metronidazole, or Flagyl, 250 milligrams orally 3 times daily, and at bedtime. And oh goody, another table. Table 58.1, commonly used complementary and alternative therapies for gastritis and peptic ulcer disease, PUD. Herbs and vitamins. Gamma-linolenic acid, or GLA. Probiotics, vitamin B12. Bromelain, vitamin A, vitamin C. Astragalus, barberry, chamomile, cranberry, dandelion, ginger, green tea, licorice, slippery elm, turmeric, and yarrow. And then homeopathy, pulsatilla, ipecacuanha, carbovegetabilis, and nux vomica. Whatever that means. Alright, back to the text. Assist the patient with various techniques that reduce stress and discomfort, such as progressive relaxation, cutaneous stimulation, guided imagery, and distraction. Other complementary and alternative therapies that have been used are listed in Table 58.1. Chapter 2 describes these therapies in detail. Surgical management. Partial gastrectomy, pyloroplasty, vagotomy, or even total gastrectomy may be needed in rare cases for patients who have major bleeding caused by severe erosive gastritis. Such surgery is necessary only if more conservative measures have not controlled the bleeding. Surgical interventions are on page 1278 in the discussion of surgical management in the peptic ulcer disease section. Okay, on to page 1316 to 1342, APP, peritonitis, gastroenteritis, ulcerative colitis, and Crohn's Crohn's disease, and diverticulitis. Okay. Inflammatory bowel habits or inflammatory bowel health problems affect the small intestine, large intestine, or colon, or both. Together, these organs are called the intestinal tract. Continued digestion of food and absorption of nutrients occur primarily in the small intestine or bowel to meet the body's needs for energy. Water is reabsorbed in the large intestine to help maintain a fluid balance and promote the passage of waste products. When the intestinal tract and its nearby structures become inflamed, digestion and nutrition may be inadequate to meet a patient's needs. Acute inflammatory bowel disorders. Appendicitis, gastroenteritis, and peritonitis are the most common acute inflammatory bowel problems. These disorders are potentially life-threatening and can have major systemic complications if not treated promptly. Appendicitis. Pathophysiology. Appendicitis, an acute inflammation of the vermiform appendix, occurs in 5% of the population. Peaking among young adults, especially men, it is the most common cause of right lower quadrant or RLQ pain. Right lower quadrant. The appendix usually extends off the proximal cecum of the colon, just below the ileocecal valve. Inflammation occurs when the lumen, or opening, of the appendix is obstructed or blocked. I didn't know obstructed meant. Okay. Leading to infection as bacteria invade the wall of the appendix. The initial obstruction is usually a result of fecaliths, or very hard pieces of feces composed of calcium phosphate-rich mucus and inorganic salts. Less common causes are malignant tumors, worms, or other infections. When the lumen is blocked, the mucosa secretes fluid, increasing the intestinal pressure and restricting blood flow, resulting in pain. If the process occurs slowly, an abscess may develop, but a rapid process may result in peritonitis or inflammation of the peritoneum. All complications of peritonitis are serious. Gangrene may occur within 24 to 36 hours, is life-threatening, and is one of the most common indications for emergency surgery. Perforation may develop within 24 hours, but the risk rises rapidly after 48 hours. Perforation of the appendix also results in peritonitis with a temperature of greater than 101 degrees Fahrenheit or 38.3 degrees Celsius, and a rise in pulse rate. Considerations for older adults. Appendicitis is relatively rare at extremes in age. However, perforation is more common in older people, causing a higher mortality rate. The diagnosis of appendicitis is difficult to establish in older adults because symptoms of pain and tenderness may not be as pronounced in this age group, resulting in treatment delay and an increased risk for perforation, peritonitis, and death. Recurrent acute appendicitis does sometimes occur, often with complete remission of inflammation between acute attacks. In rare instances, acute appendicitis may be the first manifestation of Crohn's disease. Patient-centered collaborative care assessment. History taking and tracking and the sequence of symptoms are important because nausea and vomiting before abdominal pain can indicate gastroenteritis. Nausea and vomiting before abdominal pain can indicate gastroenteritis. Abdominal pain followed by nausea and vomiting can indicate appendicitis. Okay, so abdominal pain followed by nausea and vomiting would be appendicitis. Nausea and vomiting before abdominal pain would be gastroenteritis. Is that the same thing? No, it's not. Okay. Ask about risk factors such as age, familial tendency, and intra-abdominal tumors. Classically, patients with appendicitis have cramp-like pain in the epigastric or periumbilical area. Anorexia is a frequent symptom, with nausea and vomiting occurring in many cases. Perform a complete pain assessment. Initially, pain can present anywhere in the abdomen or flank area. As the inflammation and infection progress, the pain becomes more severe and steady and shifts to the right lower quadrant, RLQ, between the anterior iliac crest and the umbilicus. This area is referred to as McBurney's point, figure 61. Abdominal pain that increases with cough or movement and is relieved by bending the right hip or knees suggests perforation and peritonitis. Assess for muscle rigidity and guarding on palpation of the abdomen. The patient may report pain after release of pressure. This is referred to as rebound tenderness. Figure 61, McBurney's point is located midway between the anterior iliac crest and the umbilicus in the right lower quadrant. This is the classic area for localized tenderness during the later stages of appendicitis. Laboratory findings do not establish the diagnosis, but often there is a moderate elevation of the white blood cell count, leukocytosis, to 10,000 to 18,000, with a shift to the left, an increased number of immature white blood cells would be left shift. A WBC elevation greater than 20,000 mm3 may indicate a perforated appendix. An ultrasound study may show the presence of an enlarged appendix. If symptoms are recurrent or prolonged, a CT scan can be used for diagnosis and may reveal the presence of a fecalith. Interventions. All patients with suspected or confirmed appendicitis are hospitalized and examined by a surgeon. When the diagnosis is not clear, the healthcare team observes the patient before surgical exploration. Non-surgical management. Keep the patient with suspected or known appendicitis on NPO to prepare for the possibility of emergency surgery and to avoid making the inflammation worse. Administer IV fluids as prescribed to prevent fluid and electrolyte imbalance and to replace fluid volume. If tolerated, advise the patient to maintain a semi-Fowler's position so that abdominal drainage, if any, can be contained in the lower abdomen. Once the diagnosis of appendicitis is confirmed and surgery is scheduled, administer opioid analgesic and antibiotic as prescribed. The patient with suspected appendicitis should not receive laxatives or enemas, which can cause perforation of the appendix. Heat should never be applied to the abdomen because this may increase circulation to the appendix and result in increased inflammation and perforation. No heat, no laxatives or enemas. Surgical management. Surgery is required as soon as possible. If the diagnosis is not definitive, but the patient is at high risk for complications from suspected appendicitis, the surgeon may perform an exploratory laparoscopy or laparotomy to rule out appendicitis. A laparoscopy is a minimally invasive surgery, or MIS, procedure with several small incisions near the umbilicus through which a small endoscope is placed. A laparotomy is an open approach with a larger abdominal incision for complicated or atypical appendicitis or peritonitis. Preoperative teaching is often limited because the patient is in pain or may be transferred quickly to the operating suite for emergency surgery. The patient is prepared for general anesthesia and surgery as described in Chapter 16. An appendectomy is the removal of the inflamed appendix by one of the two surgical approaches. Most uncomplicated appendectomy procedures today are done via laparoscopy. Often, after surgery, care of the patient who has undergone an appendectomy is the same as that required for anyone who has received general anesthesia. See Chapter 18. The patient with an MIS procedure may be discharged on the day of surgery. In a few cases, there is an overnight stay. Most patients recover quickly and return to usual activities in 2 to 3 weeks or less. Peritonitis or acid wound drains are inserted and a nasal tube may be placed to decompress the stomach and prevent abdominal distension. Administer IV antibiotics and opioid analgesics as prescribed. The patient on the evening of surgery. He or she rest for as long as 3 to 5 days and return to normal activity in 4 to 6 weeks. Peritonitis. Peritonitis is a life-threatening acute inflammation of the visceral parietal peritoneum and endothelial lining of the abdominal cavity. Primary peritonitis is rare and indicates the peritoneum is infected via the bloodstream. This problem is not discussed here. Okay. Pathophysiology. Normally, the peritoneal cavity contains about 50 milliliters of sterile fluid, or called transudate, which prevents friction in the abdominal cavity during peristalsis. When the peritoneal cavity is contaminated by bacteria, the body first begins an inflammatory reaction, walling off a localized area to fight the infection. This local reaction involves vascular dilation and increased capillary permeability, allowing transport of leukocytes and subsequent phagocytosis of the offending organisms. If this walling off process fails, the inflammation spreads and contamination becomes massive, resulting in diffuse or widespread peritonitis. Peritonitis is most often caused by contamination of the peritoneal cavity by bacteria or chemicals. Bacteria gain entry into the peritoneum by perforation from appendicitis, diverticulitis, or peptic ulcer disease, or from an external penetrating wound, a gangrenous gallbladder, bowel obstruction, or ascending infection through the genital tract. Less common causes include perforating tumors, leakage or contamination during surgery, and infection by skin pathogens in patients undergoing continuous ambulatory peritoneal dialysis, or CAPD. Common bacteria responsible for peritonitis include E. coli, Streptococcus, Staphylococcus, Pneumococcus, and Gonococcus. Chemical peritonitis results from leakage of bile, pancreatic enzymes, and gastric acid. That's chemical peritonitis. Bile, pancreatic enzymes, and gastric acid. When diagnosis and treatment of peritonitis are delayed, blood vessel dilation continues. The body responds to the continuing infectious process by shunting extra blood to the area of inflammation, or hyperemia. Fluid is shifted from the extracellular fluid compartment into the peritoneal cavity. Connective tissues and GI tract or third spacing. This shift of fluid can result in significant decrease in circulatory volume and hypovolemic shock. Severely decreased circulatory volume can result in insufficient perfusion of the kidneys, leading to kidney failure with electrolyte imbalance. Assess for clinical manifestations of problems. Peristalsis slows or stops in response to severe peritoneal inflammation, and the lumen of the bowel becomes distended with gas and fluid. Fluid that normally flows to the small bowel and the colon for reabsorption accumulates in the intestine in volumes of 7 to 8 liters daily. The toxins of bacteria responsible for the peritonitis can also enter the bloodstream from the peritoneal area and lead to bacteremia or septicemia, bacterial invasion of the blood. Respiratory problems can also occur as a result of increased abdominal pressure against the diaphragm from intestinal distension and fluid shifts to the peritoneal cavity. Pain can interfere with respirations at a time when the patient has an increased oxygen demand because of the infectious process. Patient-centered collaborative care assessment. Ask the patient about abdominal pain and determine the character of the pain, e.g. cramping, sharp aching, location of the pain, and whether the pain is localized or generalized. Ask about a history of a low-grade fever or recent spikes in temperature. Physical findings of peritonitis, chart 61, depend on several factors. The stage of the disease, the ability of the body to localize the process by walling off the infection, and whether the inflammation has progressed to generalized peritonitis. The patient most often appears acutely ill, lying still, possibly with the knees flexed, and he or she may report and show signs of pain, e.g. facial grimacing, with coughing or movement of any type. During inspection, observe for progressive abdominal distension, often seen when the inflammation markedly reduces intestinal motility. Auscultate the bowel sounds, which usually disappear with progression of the inflammation. So no bowel sounds. Observe progressive abdominal distension. Facial grimacing. Okay. Lying still. Guarded. Of peritonitis, abdominal pain, and tenderness. In the patient with localized peritonitis, the abdomen is tender on palpation in a well-defined area with rebound tenderness in this area. With generalized peritonitis, tenderness is widespread. Abdominal wall rigidity is a classic finding, sometimes referred to as a board-like abdomen. The patient may have a high fever because of the infectious process, with tachycardia occurring in response to the fever and decreased circulating blood volume. Assess whether he or she has dry mucous membranes and a low urine output seen with third spacing. Nausea and vomiting may also be present. Hiccups may occur as a result of diaphragmatic irritation. Chart 61. Key features. Peritonitis. Rigid, board-like abdomen. That's classic. Abdominal pain, localized, poorly localized, or referred to the shoulder or chest. Distended abdomen. Nausea, anorexia, vomiting, diminishing bowel sounds, inability to pass flatus or feces, rebound tenderness in the abdomen, dehydration from high fever, poor skin turgor, decreased urine output, hiccups, and possible compromise in respiratory status. White blood cell counts are often elevated to 20,000 mm3 with a high neutrophil count. Blood culture studies may be done to determine whether septicemia has occurred and to identify the causative organism to enable appropriate therapy. The healthcare provider laboratory tests to assess fluid and electrolyte balance and renal status, including electrolytes, blood urea, nitrogen or BUN, creatinine, hemoglobin, and hematocrit. Oxygen saturation and end carbon dioxide monitoring may be obtained to assess respiratory function and acid-base balance. Flat, upright, and decubitous or side flat, upright, and decubitous or side abdominal x-rays can assess for free air or fluid in the abdominal cavity, indicating perforation. The x-rays may also show dilation, edema, and inflammation of the small and large intestines. An abdominal sonogram may be useful in locating the problem. The physician may perform a diagnostic peritoneal lavage by instilling 1 liter of fluid through a peritoneal dialysis catheter. Lavage fluid positive for peritonitis is characterized by more than 500 white blood cells per milliliter of fluid, more than 50,000 red blood cells per milliliter, or the presence of bacteria on a gram stain. Bile-stained green fluid may indicate a ruptured gallbladder or perforated intestine. Green bile. Okay. Interventions. All patients with peritonitis are hospitalized because of the severe nature of the illness. If complications are extensive, they may be admitted to a critical care unit. Nursing interventions focus on the early identification of complications. Non-surgical management. The physician prescribes IV fluids and broad-spectrum antibiotics immediately after establishing the diagnosis of peritonitis. IV fluids are used to replace fluids collected in the peritoneum and bowel. Monitor daily weight and intake and output carefully. A nasogastric tube decompresses the stomach and the intestine, and the patient is NPO. Apply oxygen as prescribed and according to the patient's respiratory status. Administer analgesics and monitor pain control as needed. A surgical consultation is requested in case surgery should become necessary. Surgical management. Abdominal surgery is the usual treatment for identifying and repairing the cause of the peritonitis. If the patient is so critically ill that surgery would be life-threatening, it may be delayed. Surgery focuses on controlling the contamination, removing foreign material from the peritoneal cavity, and draining collected fluid. Exploratory laparotomy or surgical opening into the abdomen is the usual approach to remove or repair the inflamed or perforated organ, e.g. appendectomy for an inflamed appendix, or a colon resection with or without a colostomy for a perforated diverticulum. Before the abdominal cavity is closed, the surgeon irrigates the peritoneum with antibiotic solutions. Several catheters may be inserted to drain the cavity and provide a route for irrigation after surgery. The preoperative care is similar to that described in Chapter 16 for patients having general anesthesia. Chapter 18 describes general postoperative care. Multi-system complications can occur with peritonitis. Maintain the patient in a semi-Fowler's position to promote drainage of peritoneal contents into the lower region of the abdominal cavity. This position also aids in the respiratory effort. The patient has one or more incisions and drains. Because contamination at the time of surgery slows healing of an incision with edges well approximated, first intention, incisions may be allowed to heal by second or third intention. These wounds require special care involving manual irrigation or packing as prescribed by the surgeon. If the surgeon requests peritoneal irrigation through a drain, maintain sterile technique during manual irrigation. Assess whether the patient retains the fluid used for irrigation by comparing the amount of fluid returned with the amount of fluid instilled. Fluid retention could cause abdominal distension or pain. Loss of fluids from the extracellular space to the peritoneal cavity, NGT suctioning, and NPO status require that the patient receives IV fluid replacement and that intake and output are strictly measured. Fluid rates may be changed frequently based on laboratory values and patient condition. Therefore, monitoring the patient's level of consciousness and vital signs, respiratory status or respiratory rate and breath sounds, and intake and output at least hourly immediately after surgery. Community-based care. The length of hospitalization depends on the extent and severity of the infectious process. Patients who have a localized abscess drained and who respond to antibiotics and IV fluids without multi-system complications are discharged in several days. Others may require mechanical ventilation or hemodialysis with longer hospital stays. Some patients may be transferred to a transitional care unit to complete their antibiotic therapy and recovery. Convalescence is often longer than for surgeries because convalescence is often longer than for surgeries, longer than for other surgeries because of multi-system involvement. Okay. When discharged home, assess the patient's ability for self-management at home with the added task of incision care and reduced activity tolerance. Provide the patient and family with written and oral instructions to report these problems to the healthcare provider immediately. Unusual or foul-smelling drainage, swelling, redness or warmth or bleeding from the incision site, a temperature higher than 101 Fahrenheit, 38.3 Celsius, abdominal pain, signs of wound dehiscence or ileus. Also, instruct the patient and family in proper hand washing and dressing change techniques, which include directions to dress each wound separately to avoid cross-contamination. Review information about antibiotics and analgesics for patients taking oral opioid analgesics such as oxycodone with acetaminophen, Tylox, Percocet, Endocet, for any length of time. A stool softener such as docusate, sodium, or Colace, Regulex may be prescribed. Older adults are especially at risk for constipation from codeine-based drugs. Explain nutrition and activity limitations. Nutrition therapy depends on the type of surgery performed and the patient's specific food tolerances at discharge. Tell all patients to refrain from any lifting or for at least 6 weeks. Other activity limitations are made on an individual basis with the physician's recommendation. Patients with an incision healing by second or third intention may require dressings, solution, and catheter-tipped syringes to irrigate the wound. A home care nurse may be needed to assess, irrigate, and or pack the wound and change the dressing as needed until the patient and family feel comfortable with the procedure. If the patient needs assistance with ADLs, a home care aide or temporary placement in a skilled care facility may be indicated. Collaborate with the case manager to determine the most appropriate setting for seamless continuing care in the community. Gastroenteritis. Pathophysiology. Acute diarrheal illnesses are a significant health problem among adults, especially in less affluent countries. Gastroenteritis is an increase in the frequency and water content of stools or vomiting as a result of inflammation of the mucous membranes of the stomach and intestinal tract. It affects mainly the small bowel and can be caused by either viral or bacterial infections, which have similar manifestations. They are considered self-limiting in their course unless complications occur. All organisms implicated in gastroenteritis cause diarrhea. However, the organisms discussed in this section have distinguishing characteristics. Some clinicians include shigellosis when discussing gastroenteritis. Others consider shigellosis separately as a dysentery type of illness. Dysenteries affect the large bowel. Gastroenteritis affects the small bowel. Other clinicians classify infectious disease of the intestine as bacterial, viral, or parasitic without using the term gastroenteritis. Food poisoning is sometimes described in conjunction with gastroenteritis with specific reference to the organism causing the food poisoning. Gastroenteritis, however, differs from food poisoning with regard to transmission in the body, incubation time, and effect on immunity. The following discussion of gastroenteritis includes the epidemic viral form and the bacterial forms, Campylobacter, E. coli, and shigellosis. Table 61. Organisms associated with food poisoning from parasites are discussed on page 1340 in the parasitic infection section. Infection with viral and bacterial organisms can produce GI illnesses that cause watery diarrhea. These disorders may be caused by non-inflammatory, inflammatory, or penetrating mechanisms. Organisms such as enterotoxigenic E. coli can release enterotoxin, a non-inflammatory toxic substance specific to the intestinal mucosa, which results in diarrhea. Shigella, or Campylobacter, can attach itself to a mucous epithelium without penetrating it, resulting in destruction of the intestinal villi and malabsorption. Infections that are caused by bacterial toxins reduce the absorptive capacity of the distal small bowel and proximal colon, resulting in diarrhea. Finally, the organism can penetrate the intestine, causing cellular destruction, necrosis, and a potential for ulceration. Diarrhea occurs often with white blood cells, or WBCs, or red blood cells, RBCs, present in the stool. All of these organisms are transmitted via the oral fecal route and result in increased GI motility, with fluids and electrolytes being secreted into the intestine at rapid rates. Invading organisms more easily attach to the intestinal mucosa if the normal intestinal flora is altered. This can occur in patients who are receiving antibiotics, are malnourished, or are debilitated. Two groups of viruses, the rotavirus, which usually affect young children, and Norwalk virus, as well as bacterial pathogens, are the most common causes of gastroenteritis. Rotavirus can also affect older adults in group settings such as long-term care facilities. Table 61. Common types of gastroenteritis and their characteristics. Viral gastroenteritis. It'd be epidemic viral. It's caused by many parvovirus type organisms, transmitted by the fecal oral route in food and water. Incubation period is 10 to 51 hours. Communicable during acute illness. Then there's the rotavirus and Norwalk virus. These are transmitted by the fecal oral route and possibly the respiratory route. Incubation in 48 hours. Rotavirus is most common in infants and young children. Norwalk virus affects young children and adults. Bacterial gastroenteritis. That would be caused by Campylobacter enteritis, or it's called Campylobacter enteritis. It's transmitted by the fecal oral route or by contact with infected animals or infants. Incubation period 1 to 10 days, and communicable for 2 to 7 weeks. There's E. coli, diarrhea, shigellosis, and that'd be transmitted by fecally contaminated food, water, or fomites. Transmitted by direct and indirect fecal oral routes. Incubation period is 1 to 7 days. Communicable during the acute illness to 4 weeks after the illness. And humans possibly carriers for months. Types of gastroenteritis. Viral gastroenteritis. Norwalk virus infection can occur year-round and affects adults and children. This virus is responsible for 1/3 of all epidemics of viral gastroenteritis in affluent countries and is a common cause of waterborne epidemics of gastroenteritis. Bacterial gastroenteritis. The three most common types of bacterial gastroenteritis are E. coli diarrhea, or traveler's diarrhea, Campylobacter enteritis, it's another type of traveler's diarrhea, and shigellosis, or bacillary dysentery. The reservoirs of E. coli are humans, who are often asymptomatic. The etiologic feature of Campylobacter enteritis is the bacterium Campylobacter jejuni. Reservoirs are domestic or wild animals and birds. Incubation ranges from 1 to 10 days. The organism is communicable for several days to weeks throughout the course of the infection, usually 2 to 7 weeks. Shigellosis is caused by infection with Shigella bacteria. The incubation period before the illness is 1 to 7 days. The illness can be communicated during the acute phase and for up to 4 weeks after the onset of illness. A person can be a carrier of this illness for months after the acute illness. Incidence and prevalence. Acute diarrhea illnesses are the most common cause of morbidity and mortality among children and older adults in Asia, Africa, and Latin America. Gastroenteritis often occurs in epidemic outbreaks. Diarrhea caused by E. coli and Campylobacter occur worldwide, commonly in epidemic outbreaks. E. coli epidemics are highest in areas of poor sanitation during warm months. Campylobacter incidence is highest during warm months. Shigellosis occurs in every age group, but most frequently in children younger than 10 years and older adults because of their depressed immune systems. Outbreaks of shigellosis are common in areas with crowded living conditions. Patient-centered collaborative care. Assessment. The patient history can provide information related to potential cause of the illness. Ask about recent travel, especially to tropical regions of Asia, Africa, or Central or South America. Some areas of Mexico may also be the source of gastroenteritis. Newcomers or immigrants from these countries often have gastroenteritis. Travelers' diarrhea can begin 3 days to 2 weeks after the patient's arrival. The patient who has gastroenteritis usually looks ill. Nausea and vomiting can occur with all types of gastroenteritis, but are usually limited to the first 1 or 2 days. Patients have diarrhea, which varies in consistency and amount with causative organism. With the causative organism. In patients with epidemic viral gastroenteritis, myalgia or muscle aches, headache, and malaise are often reported. Note any abdominal distension, auscultate for hyperactive bowel sounds, and assess for diffuse tenderness on palpation. However, there should be no rebound tenderness, which might indicate peritonitis. Depending on the amount of fluids lost through diarrhea and vomiting, patients may have varying degrees of dehydration manifested by poor skin turgor, dry mucous membrane, orthostatic blood pressure changes, hypotension, and oliguria. In some cases, dehydration may be severe, and shock may occur if diarrhea is prolonged. Dehydration occurs rapidly in older adults and may require hospitalization. Diarrhea associated with epidemic viral gastroenteritis is commonly limited to 24 to 48 hours. Infection with the Norwalk virus has a rapid onset of nausea, abdominal cramps, vomiting, and diarrhea. This enteritis is usually mild. Campylobacter enteritis is a more severe disease with foul-smelling stools containing blood, which can number 20 to 30 per day for up to 7 days. Eesh. E. coli gastroenteritis may or may not have blood or mucus in the stool. Diarrhea can last for up to 10 days. Shigella causes stools to have blood and mucus, which can continue for up to 5 days. As part of the laboratory assessment, gram stain of stool is usually done before culture. Cultures positive for the organism are diagnostic. Many WBCs on gram stain suggest shigellosis. The presence of WBCs and RBCs in the stool WBCs and RBCs in the stool indicate Campylobacter enteritis. Interventions. For any type of gastroenteritis, encourage fluid replacement. The amount and route of fluid administration are determined by the patient's hydration status. Fluid replacement. Teach patients to drink extra fluids to replace fluid lost through vomiting and diarrhea. Patients may be admitted to the hospital for gastroenteritis if they require IV fluid replacement, or they may stay in the emergency department or urgent care center until they are rehydrated. Commercially prepared rehydration products, e.g. Pedialyte or IV therapy, may prevent hospitalization. Caffeine should be avoided because it increases intestinal mobility and contributes to dehydration. Obtain a weight orthostatic blood pressure, and other vital sign measurements at admission. IV fluids such as half-strength normal saline or 0.45% sodium chloride with or without potassium supplements are infused as prescribed. Potassium is usually needed for patients with excessive diarrhea. Continue to monitor the patient's vital signs, intake and output, and weight. A rapid gain or loss of 1 kilogram or 2.2 pounds of body weight is equivalent to the gain or loss of 1 liter of fluid. Use standard precautions when handling vomitus and stool. Advise the patient to alternate periods of rest and activity. Depending on the type of gastroenteritis, especially if the geographic area is experiencing epidemic infections, the local health department may need to be notified. For example, it is mandatory that every case of shigellosis be reported. In some endemic areas, Campylobacter enteritis must be reported. Drugs that suppress intestinal motility, such as anticholinergics and antiemetics, are not routinely given for bacterial or viral gastroenteritis. Use of these drugs can prevent the infecting organism from being eliminated from the body. Okay. If the health care provider determines that the antiperistaltic agents are necessary, an initial dose of loperamide or Imodium 4 milligrams can be administered orally, followed by 2 milligrams after each loose stool, up to 16 milligrams daily. Bismuth subsalicylate or Pepto-Bismol 30 milliliters or 2 tablets every 30 minutes for a maximum of 8 doses can be given to reduce the watery volume of the stool. Diphenozate or diphenozylate hydrochloride with atropine sulfate or Lomotil or Lominate reduces GI motility but is used sparingly because of its habit-forming ability. Okay, test. I lost where I was, so I'm going to start at drug therapy. Sorry if I read it already. Drug therapy. Drugs that suppress intestinal motility, such as anticholinergics and antiemetics, are not routinely given for bacterial or viral gastroenteritis. Use of these drugs can prevent the infecting organisms from being eliminated from the body. If the health care provider determines that antiperistaltic agents are necessary, an initial dose of loperamide or Imodium 4 milligrams can be administered orally, followed by 2 milligrams after each loose stool, up to 16 milligrams a day. Bismuth subsalicylate or Pepto-Bismol 30 milliliters or 2 tablets every 30 minutes for a maximum of 8 doses can be given to reduce the watery volume of the stool. Diphenoxylate hydrochloride with atropine sulfate or Lomotil or Lominate reduces GI motility but is used sparingly because of its habit-forming ability. The drug should not be used for older adults because it also causes drowsiness and could contribute to falls. Treatment with antibiotics may be needed if the gastroenteritis is due to bacterial infection with fever and severe diarrhea. The healthcare provider may prescribe norfloxacin or Norazin 400 milligrams orally twice daily, or ciprofloxacin or Cipro 500 milligrams orally twice daily for 3 days or more. If the gastroenteritis is due to shigellosis, anti-infective agents such as trimethoprim or sulfamethoxazole or Septra DS or Bactrim DS Robic are prescribed. For relatively short-term diarrhea of 24 to 48 hours duration, the diagnosis is based primarily on the patient's history and clinical manifestations, not by a stool examination. When diarrhea is severe or persists for long periods, the stool is examined to determine the causative organism and to begin specific treatment. It should be determined whether the diarrhea is caused by salmonella or by parasites, because these organisms respond to specific medications. See page 1339 in the parasitic infection section. Diarrhea that continues longer than 10 days, especially if associated with nocturnal diarrhea, is probably not due to gastroenteritis. Skin care. Frequent stools that are rich in electrolytes and enzymes, as well as frequent wiping and washing of the anal region, can irritate the skin. Teach the patient to avoid toilet paper and harsh soaps. Ideally, he or she can gently clean the area with warm water or absorbent cotton, followed by thorough drying with absorbent cotton. Cream, oil, or gel can be applied to a damp, warm washcloth to remove stool that sticks to open skin. Special prepared skin wipes can also be used. Hydrocortisone cream or protective barrier cream can be applied to the skin between stools. A sitz bath for 10 minutes 2 or 3 times daily can also relieve discomfort. If leakage of stool is a problem, the patient can put absorbent cotton next to the anal orifice and keep it in place with snug underwear. For patients who are incontinent, remind unlicensed assistance personnel (UAP) to keep the perineal and buttock areas clean and dry. The use of incontinent pads at night instead of briefs allows air to circulate to the skin and prevents irritation. Health teaching. During the acute phase of the illness, teach the patient and family about the importance of fluid replacement. Teaching the patient and family about reducing the risk for transmission of gastroenteritis is also important. Chart 62. Adhere to these precautions for up to 7 weeks after the illness, or up to several months if Shigella was the offending organism. Inflammatory bowel disease. Okay, although a patient can have idiopathic or unknown cause inflammatory bowel disease, IBD, the term usually refers to disorders of the GI tract with no known etiology. Ulcerative colitis and Crohn's disease, or no known etiology, for example, ulcerative colitis and Crohn's disease. Comparisons and differences are listed in Table 62. Viral and bacterial dysenteries can cause symptoms similar to those of IBD, and other problems must be ruled out before a definitive diagnosis is made. Chart 62, Patient and Family Education Guide, Preventing Transmission of Gastroenteritis. Advise the patient to wash hands well for at least 30 seconds with an antibacterial soap, especially after a bowel movement, and maintain good personal hygiene. Tubes of toothpaste for their own use. In severe cases, disposable utensils may be wise. Maintain room facilities with exposure to stool. Inform the healthcare provider if symptoms persist beyond 3 days, and do not prepare or handle food that will be consumed by others. The patient should be consulted for recommendations about the return to work. Okay, ulcerative colitis, pathophysiology. Ulcerative colitis creates widespread inflammation of mainly the rectum and rectosigmoid, but can extend to the entire colon. Backwash ileitis, evident in the terminal ileum when the disease is extensive. Distribution of the disease can remain constant for years. UC is a disease that is associated with periodic remission. Reddened. In more severe inflammation, the lining can bleed and small erosions or ulcers occur. Abscesses can form in these ulcerative areas and result in tissue necrosis or cell death. Continued edema and mucosal thickening can lead to a narrowed colon and possibly a partial bowel obstruction. Table 63 lists the categories of the severity of UC. The patient's stool typically contains blood and mucus. Patients report tenesmus, or an unpleasant and urgent sensation. Lower abdominal colicky pain relieved with defecation. Malaise, anorexia, and weight loss are common. Anemia occurs less often. Extraintestinal manifestations such as migratory polyarthritis, ankylosing spondylitis, and erythema nodosum are present in some patients. Gallstones are also common. The complications of UC are listed in Table 64. With long-term disease, cellular changes can occur that increase the risk for colon cancer. Damage to inflammatory cytokines, or e.g. interleukins, IL-1, IL-6, and IL-8, and tumor necrosis factor, TNF, TNF-alpha have cytotoxic effects on the colonic mucosa. Therefore, annual colonoscopies are recommended when the patient has longer than a 10-year history of UC involving the entire colon. Primary sclerosing cholangitis, or PSC, is a chronic fibrosing infection of the intrahepatic, extrahepatic bile ducts that can develop into cirrhosis and commonly occurs with UC. Table 62, differential features of UC and Crohn's disease. Feature, location. Ulcerative colitis begins in the rectum and proceeds in a continuous manner toward the cecum. Crohn's disease most often in the terminal ileum with patchy involvement through all layers of the bowel. Etiology unknown for both. Peak 15 to 25 years and 55 to 65 years for ulcerative colitis, and for Crohn's disease 15 to 40 years. That's a peak incidence at age. Okay, so number of stools for ulcerative colitis would be 10 to 20 liquid bloody stools per day, and for Crohn's disease would be 5 to 6 soft loose stools per day, non-bloody. Complications for ulcerative colitis would be hemorrhage, nutritional deficiencies, and for Crohn's would be fistulas are common, and nutritional deficiencies. Need for surgery in ulcerative colitis would be infrequent, and need for surgeries in Crohn's disease would be frequent. So, for UC, infrequent for Crohn's. Okay. Etiology and genetic risk. The exact cause of UC is unknown. A genetic basis of the disease has been proposed because it is often found in families and twins. Immunological causes, including autoimmune dysfunction, have been explored because of the extraintestinal manifestations of the disease. Epithelial antibodies in the IgG class have been identified in the blood of some patients with UC. Table 63, American College of Gastroenteritis classification of UC severity. So mild would be 4 stools a day with or without blood, and signs and symptoms would be asymptomatic or laboratory values usually normal. Severity moderate would be greater than 4 stools a day with or without blood. Minimal symptoms, mild abdominal pain, mild intermittent nausea, possible increased C-reactive protein or ESR. Severe would be greater than 6 bloody stools per day, fever, tachycardia, anemia, abdominal pain elevated, C-reactive protein and or ESR. And then fulminant would be greater than 10 bloody stools per day, and that would be increasing symptoms, anemia, may require transfusion, colonic on X-ray. So a note here, C-reactive sensitive serum marker that is evident in the first 6 hours of an inflammatory process. An ESR is erythrocyte sedimentation rate, may be helpful but is less sensitive than C-reactive protein. So IBD, I think that's bowel disorder or something like that, may result from an abnormal IBD may result from an abnormal response to normal flora present in the intestine. Another possibility is that there may be a defect and intestinal permeability that permits antigens to leak through the mucosa, stimulating an inflammatory response. Psychological factors may result in an exacerbation of the disease. However, little evidence has been found to relate psychological factors to the cause of the disease. Incidence and prevalence. The disease occurs in Northern Europe, and North America. It affects about 2 million people in the United States. A person's risk for the disease is 10 times greater if he or she has a first-degree relative, parent, sibling, or child with the disease. Peak age is between 20 and 40 years old, and again at 55 to younger years, or 55 to 65 years old. Women are more often affected than men in their younger years, but men have the disease more often as middle-aged and older adults. People who do not smoke or those who are smoking are at higher risk for having UC than people who smoke. People who do not smoke or those who quit smoking are at a higher risk for having UC than people who smoke. Whoa. Wow. One for the smokers. The reason for this relationship is not known, but nicotine has a positive influence on smooth muscle of the colon. Holy crap. It's amazing. Cultural awareness. Ulcerative colitis is 4 to 5 times more common among people of European, Jewish, or Sephardic origin and commonly affects Euro-American people. The reasons for this ethnic difference are not known. Patient-centered collaborative care. Assessment. History. Collect data on family history of IBD, previous and current therapy for the illness, and the dates and types of surgery. Obtain a nutrition history, including intolerance of milk and milk products and fried, spicy, or hot foods. Ask about usual bowel elimination pattern, color, consistency, character of the stool, abdominal pain, tenesmus, anorexia, and fatigue. Note any relationship between diarrhea, timing of meals, emotional distress, and activity. Inquire about recent past 2 to 3 months exposure to antibiotics suggesting a C. diff infection. Has the patient traveled to or immigrated from tropical areas? Ask about recent use of NSAIDs that can either present with the initial diagnosis or cause a flare-up of the disease. Ask about any extra-intestinal symptoms such as arthritis, mouth sores, vision problems, and skin disorders. Ask if the patient smokes or if symptoms began after smoking cessation. Table 64. Complications of ulcerative colitis disease. Complication: hemorrhage or perforation. Description: lower gastrointestinal bleeding results from erosion of the bowel wall. Abscess formation would be localized pockets of infection develop in the ulcerated bowel lining. Toxic megacolon would be paralysis of the colon, causes dilation and subsequent colonic ileus, possibly perforation. Malabsorption would be essential nutrients cannot be absorbed through the diseased intestinal wall, causing anemia and malnutrition. Most common in Crohn's disease would be malabsorption. Non-mechanical bowel obstruction would be obstruction results from toxic megacolon or cancer. Fistulas would be in Crohn's disease, in which the inflammation is transmural. Fistulas can occur anywhere, but usually track between the bowel and bladder, resulting in pyuria and fecaluria. And then colorectal cancer. Patients with ulcerative colitis with a history longer than 10 years have a high risk for colorectal cancer. This complication accounts for about 1/3 of all deaths related to UC. Extraintestinal complications include arthritis, hepatic and biliary disease, especially colitis, oral and skin lesions, and ocular disorders such as iritis. The cause is unknown. Osteoporosis. Osteoporosis occurs especially in patients with Crohn's disease. Physical assessment, clinical manifestations. Symptoms vary with an acuteness of onset. Vital signs are usually within normal limits in mild disease. Fever 99 to 100 degrees, 37.2 to 37.8 Celsius. The physical assessment findings are usually nonspecific, and in milder cases, the physical examination may be normal. Viral and bacterial infections infections can cause similar symptoms to those of UC. Note any abdominal distension along the colon. Palpation may reveal areas of increased or localized tenderness. Rebound tenderness may suggest peritonitis. Patients with associated with tachycardia, peritonitis, dehydration, and bowel perforation. Okay, so fever and tachycardia. Okay, so psychosocial assessment. Many patients are very concerned about the frequency of stools and the presence of blood. The inability to control the disease symptoms, particularly diarrhea, can be disruptive and stress-producing. Severe illnesses may limit the patient's activities outside the home, with fear of fecal incontinence resulting in feeling tied to the toilet. Eating may be associated with pain and cramping and an increased frequency of stools. Mealtimes may become unpleasant experiences. Frequent visits to healthcare providers and close monitoring of the colon mucosa for abnormal cell changes can be anxiety-provoking. Assess the patient's understanding of the illness and its impact on his or her lifestyle. Encourage and support the patient while exploring the relationship of life events to disease exacerbations, stress factors that produce symptoms, family and social support systems, concerns regarding the possible genetic basis and associated cancer risks of the disease, internet access for reliable education information. Laboratory assessment. As a result of chronic blood loss, hematocrit and hemoglobin levels may be low, which indicates anemia and a chronic disease state. An increased WBC count, platelet count, C-reactive protein, or erythrocyte sedimentation rate, ESR, is consistent with inflammatory disease. Blood levels of sodium, potassium, and chloride may be low as a result of frequent diarrheal stools and malabsorption through the diseased bowel. Hypoalbuminemia, decreased serum albumin, is found in patients with extensive disease from losing protein in the stool. Other diagnostic assessments. A colonoscopy is the most definitive test for diagnosing UC. In some cases, a CT scan may be done to confirm the disease or its complications. Barium enemas with air contrast can show differences between UC and Crohn's disease and identify complications, mucosal patterns, and the distribution and depth of disease involvement. In early disease, the barium enema may show incomplete filling as a result of inflammation and fine ulcerations along the bowel contour, which appear deeper in more advanced disease. Decision-making challenge. Coordination of care. A 43-year-old woman who has 10 to 15 watery loose stools per day since she stopped smoking is admitted to the ED. Bloody mucus is mixed with her stool. She has had no weight loss but has cramping and lower abdominal pain, relieved after her bowel movement. Stools for CNS, ova, and parasites and C. diff at her primary care provider's office were negative. She is now admitted for dehydration. 1. What questions should you ask to obtain a thorough history? What questions? And what other physical assessment should you perform at this time? What other healthcare team members will likely be involved in this patient's assessment? What laboratory tests will most likely be requested? And what might they show? What interventions will most likely be prescribed to treat this patient's dehydration? Analysis. Common nursing diagnoses and collaborative problems. The priority nursing diagnoses for patients with ulcerative colitis are diarrhea related to inflammation of the bowel mucosa, and acute pain and chronic pain related to inflammation and ulceration of the bowel mucosa and skin irritation. The primary collaborative problem is potential for lower GI bleeding with possible anemia. Additional nursing diagnoses and collaborative problems. In addition to the common nursing diagnoses and collaborative problems, patients with UC may have imbalanced nutrition, less than body requirement related to inability to absorb food because of biological factors, disturbed body image related to biophysical factors and possible surgery, activity intolerance related to generalized weakness, risk for deficient fluid volume related to diarrhea, potential for colon cancer related to long-term history of UC. Planning and implementation. Diarrhea, planning expected outcomes. The major concern for a patient with ulcerative colitis is the occurrence of frequent bloody diarrhea and fecal incontinence from tenesmus or straining. Therefore, with treatment, the patient is expected to have formed stools and normal elimination pattern with control of bowel movements. Interventions. Many measures are used to relieve symptoms and to reduce intestinal motility, decrease inflammation, and promote intestinal healing. Chart 63. Non-surgical and surgical management may be needed. Chart 63. Intervention activities. The patient with inflammatory bowel disease. Diarrhea management and alleviation of diarrhea. Instruct patient family members to record color, volume, frequency, and consistency of stools. Identify factors, e.g. medications, bacteria, tube feedings, that may cause or contribute to diarrhea. Teach the patient to eliminate gas-forming and spicy foods from diet. Suggest trial elimination of foods containing lactose. Instruct in low-fiber, high-protein, high-calorie diet as appropriate. Teach patient appropriate use of antidiarrheal medications. Monitor skin and perianal area for irritation and ulceration. Weigh patient regularly. Perform actions to rest the bowel. NPO, liquid diet. Pain management, alleviation of pain or a reduction in pain to a level of comfort that is acceptable to the patient. So for pain, perform a comprehensive assessment of pain to include location, characteristics, onset, duration, frequency, quality, intensity, or severity, and precipitating factors. Evaluate with the patient and the healthcare team the effectiveness of past pain control measures that have been used. Reduce or eliminate factors that can precipitate or increase the pain experience, e.g. fear, fatigue, monotony, and lack of knowledge. Teach the use of non-pharmacologic techniques, e.g. biofeedback, hypnosis, relaxation, guided imagery, music therapy, distraction, activity therapy, acupressure, hot-cold application, and massage. Before, after, and, if possible, during painful activities. Before pain occurs or increases and along with other pain relief measures. NIC interventions, activities, blah, blah, blah. Non-surgical management. Non-surgical management includes drug and nutrition therapy. The use of physical and emotional rest is also an important consideration. Teach the patient to record color, volume, frequency, and consistency of stools to determine severity of the problem. Monitor the skin in the perianal area for irritation and ulceration resulting from loose, frequent stools. Stool cultures may be sent for analysis if diarrhea continues. Teach the patient and family members about the correct use of antidiarrheal drugs. Have the patient weigh himself or herself 1 or 2 times per week. If the patient is hospitalized, remind unlicensed assistive personnel to weigh him or her on admission and daily and document all weights. Drug therapy. Common drug therapy for UC includes aminosalicylates, glucocorticoids, immunomodulators, and antidiarrheal drugs. The aminosalicylates are a class of drug used to treat mild to moderate UC and or maintain remission after accomplished by other treatments. 4 aminosalicylate compounds are available. All deliver 5-aminosalicylic acid, or 5-ASA, to the affected area. The method of action is unknown but thought to have an anti-inflammatory effect by inhibiting prostaglandins. These agents are effective in 2 to 4 weeks. Sulfasalazine, or azulfidine, or azulfidine N-tabs, is metabolized by the intestinal bacteria into 5-ASA, which delivers the beneficial effects of the drug, and sulfapyridine, which is responsible for the side effects: nausea, vomiting, anorexia, folate malabsorption, and headache. With higher doses, rash, hemolytic anemia, hepatitis, male infertility, or granulocytosis can occur. This drug is in the same family as sulfonamide antibiotics. Therefore, assess the patient for an allergy to sulfonamide or other drugs that contain sulfur, such as furosemide. The use of a thiazide diuretic is a contraindication for sulfasalazine. Mesalamine, or acetol, pentasa, or Rowasa, is the generic name for 5-ASA. This drug is better tolerated than sulfasalazine, with side effects of headache and GI upset. Acetol is an enteric-coated drug and is released in the terminal ileum and right side of the colon. Pentasa is a delayed-release drug and is released throughout the small bowel and colon to the rectum. Rowasa is a suppository or enema used nightly to treat left-sided disease. Topical agents, suppository or an enema, have minimal systemic absorption and therefore have fewer side effects. Valsalazide, or Colizol, releases 5-ASA and is well tolerated with headache and abdominal pain as the primary side effects. It is distributed mainly in the colon itself, with little drug effectiveness in the terminal ileum. Table 65 lists recommended doses for the 5-ASA drugs. Glucocorticoids such as prednisone and budesonide are corticosteroid therapies prescribed during exacerbation of the disease. Prednisone or deltazone, Winpred, 40 to 65 milligrams daily is usually given orally. Once clinical improvement occurs, the corticosteroids are tapered because of the adverse effects that commonly occur with long-term steroid use, e.g. hyperglycemia, osteoporosis, peptic ulcer disease, increased risk for infection. For patients with rectal symptoms, topical steroids in the form of small retention enemas may be prescribed. Hydrocortisone rectal foam, or cortifoam, is prescribed as 1 to 2 times daily for 2 to 3 weeks, and then every other day. Hydrocortisone enemas, or cordenema, are given at bedtime for 21 days, tapered and discontinued. Immunomodulators are drugs that alter a person's immune response. They are not thought to be effective in the treatment of UC. However, in combination with steroids, they may offer a synergistic effect to a quicker response, thereby decreasing the amount of steroids needed. For example, cyclosporin used in severely ill patients might avoid an emergent colectomy. Immunosuppressants used with UC and Crohn's disease include azithromycin, mercaptopurine, cyclosporin, methotrexate, infliximab, and adalimumab. Yeah, right. To provide symptomatic management of diarrhea, antidiarrheal drugs may be prescribed. These drugs are given very cautiously, however, because they can cause colon dilation and toxic megacolon. Common antidiarrheal drugs include diphenoxylate, hydrochloride, and atropine sulfate, Lomotil, and loperamide or Imodium. Although not approved as a first-line therapy for UC, infliximab or Remicade may be used for refractory disease or for severe complications such as a toxic megacolon. Massive dilation of the colon can lead to peritonitis. Remicade is an immunoglobulin G or IgG monoclonal antibody that reduces the activity of tumor necrosis factor TNF to decrease inflammation. Adalimumab or Humira is another monoclonal antibody recently approved for refractory cases. They are used more commonly in management of Crohn's disease. These drugs cause immune suppression and should be used with caution. Teach the patient to report any signs of beginning infection, including a cold, and to avoid large crowds or others who are sick. Table 65, recommended doses of 5-ASA medications. Generic name, sulfasalazine. Trade name, azolfultidine. Okay, well, I'm not going to go through these because we just did. Okay, nutrition therapy. Patients with severe symptoms are kept NPO to ensure bowel rest. The physician may prescribe total parenteral nutrition, or TPN, for severely ill and malnourished patients. Chapter 63 describes this therapy in detail. Patients with less severe symptoms may drink elemental formulas such as Vivinex, which are absorbed in the small bowel and reduce bowel stimulation. Those with significant but less severe symptoms may be restricted to a low-fiber or low-residue diet. Although a fiber-restricted diet remains controversial, teach the patient to limit or omit foods that cause him or her discomfort or diarrhea. Often lactose-containing foods are poorly tolerated and should be reduced or eliminated. Warn the patient that caffeinated beverages, pepper, alcohol, and smoking are common GI stimulants that could cause discomfort. Smoking and other forms of nicotine have been shown to help healing ulcerative colitis, but this approach is not recommended. Rest. At the onset of treatment, activity is generally restricted because rest can reduce intestinal activity, provide comfort, and promote healing. Ensure that the patient has easy access to bedpan, bedside commode, or bathroom in case of urgency or tenesmus. Complementary and alternative therapies. In addition to nutritional changes, complementary and alternative therapies may be used to supplement traditional management of ulcerative colitis. Examples include herbs such as flaxseed, selenium, and vitamin C. Biofeedback, hypnosis, yoga, acupuncture, and Ayurveda, a combination of diet, yoga, herbs, and breathing exercises, may also be helpful. These therapies have no proven efficacy in randomized double-blind studies to date, but some patients find them helpful. Surgical management. Some patients with UC require a colectomy, or surgical colon removal, and ileostomy. Indications for surgery include bowel perforation, toxic megacolon, hemorrhage, dysplastic biopsy results, failure of conventional treatment, and colon cancer. Preoperative care. General preoperative teaching related to abdominal surgery is described in Chapter 16. When an ileostomy is indicated, provide an in-depth explanation to the patient and family. An ileostomy is a procedure in which a loop of the ileum is placed through the abdominal wall, or stoma. The drainage of fecal material into a pouching system worn on the abdomen. The pouching system consists of a solid skin barrier or wafer to protect the skin and a fecal collection device, or pouch. The surgeon usually consults with a certified wound or ostomy continence nurse, a CWOCN, or enterostomal therapist, ET, sometimes called an ostomy nurse, before surgery for recommendations on the best location of the stoma. A visit from an ostomate, a patient with an ostomy, may be helpful before surgery. Oral or parenteral antibiotics such as neomycin sulfate, myocypridine are prescribed as a bowel antiseptic. Cleansing the bowel with enemas or laxatives may also be needed, although the value of preoperative bowel preparation is currently being questioned. Operative procedures. Any one of several surgical approaches may be used for patient with UC. The traditional approach involves a large open incision that cuts through layers of muscle and subcutaneous tissue to create a surgical diversion. The newer minimally invasive surgery, MIS, via laparoscopy for ulcerative colitis involves several small incisions that lead to faster recovery. Patients who are obese have had previous abdominal surgeries or have dense scar tissue are not candidates for this technique. Total proctocolectomy with a permanent ileostomy. Total proctocolectomy or colectomy with a permanent ileostomy has traditionally been the standard surgical procedure for patients undergoing a colectomy and involves the removal of the colon, rectum, and anus with surgical closure of the anus. Ouch. The surgeon brings the end of the ileum out through the abdominal wall and forms a stoma or ostomy. The stoma, figure 62b, is usually placed in the right lower quadrant of the abdomen below the belt line. It should not be prolapsed or retract into the abdominal wall. The stoma should be pinkish to cherry red because it should be receiving an adequate blood supply. If it looks pale, bluish, or dark, report these findings to the healthcare provider immediately. With a permanent ileostomy, initially after surgery, the output is a loose, dark green liquid that may contain some blood. Over time, a process called ileostomy adaptation occurs. The small intestine begins to perform some of the functions that had previously been done by the colon, including the absorption of increased amounts of sodium and water. Stool volume decreases, becomes thicker, paste-like, and turns yellow-green or yellow-brown. The effluent or fluid material usually has little odor or a sweat odor. Any foul or unpleasant odor may be a symptom of a problem such as a blockage or infection. The ostomy drains frequently and the stool is irritating. The patient must wear a pouch system at all times. The stool from the small intestine contains many enzymes and bile salts, which can quickly irritate and injure the skin. Skin care around the stoma is a priority! Exclamation point. A pouch system with a skin barrier. Pouch system with a skin barrier or gelatin or pectin provides sufficient protection for most patients. Other products are also available. Total colectomy with a continent ileostomy. As an alternative to the traditional ileostomy with an external pouch, the surgeon may create an internal system, a Cox ileostomy, or ileal reservoir, referred to as a continent ileostomy. The surgeon constructs an intra-abdominal pouch or reservoir from the terminal ileum, where stool is stored via a nipple-like valve in the pouch until the patient drains it by using a catheter. Immediately after surgery, an indwelling catheter, urinary catheter, is placed in the pouch and is connected to low intermittent suction and irrigated as prescribed. Monitor the character and quality of effluent drainage. Teach the patient to drain the stoma. Initially, the pouch holds only 50 to 75 milliliters. Over time, the pouch stretches and can hold 500 to 700 milliliters. When the pouch needs to be emptied, the patient has a sensation of fullness. The patient drains the pouch several times a day and wears a small dressing to keep the stoma moist and protect clothing. This procedure allows for minimal skin irritation. The patient does not need to wear an external pouch. Unfortunately, the need for surgical adjustments and problems with leakage and the development of ilioanal anastomosis have made this procedure less desirable. Total colectomy with ilioanal anastomosis. This procedure involves the surgical removal of the colon and the rectum and sutures the ileum into the anal canal or small cuff of rectum. Usually continence is excellent after this procedure, but many patients have some leakage of stool during sleep. Perianal irritation can be a problem. Teach patients who have this surgery to use frequent and careful perineal care. Ilioanal anastomosis occurs in two stages. First, the surgeon removes the rectal mucosa, performs an abdominal colectomy, constructs the reservoir or pouch to the anal canal, and creates a temporary loop ileostomy. The loop ileostomy allows healing of the internal pouch and all anastomosis sites and allows for an increase in the capacity of the internal reservoir through fluid installations. After 3 to 4 months, the patient returns to have the loop ileostomy closed. Stool formation resembles that in the patients who have undergone a traditional ileostomy. Ilioanal reservoir. The creation of an ilioanal reservoir, also known as a J-pouch, has become popular for many patients with UC, especially young adults, because it spares the rectal sphincter and eliminates the need for any ostomy. The surgeon removes the colon and sutures the ileum into the rectal stump to form a reservoir. If residual rectal mucosa remains after either an ilioanal anastomosis or a reservoir procedure, Proctoscopy is done on a regular basis to monitor for dysplasia or abnormal cells. Postoperative care. Provide general postoperative care after surgery as described in Chapter 18. All patients requiring open approach surgery for UC have a large abdominal incision. At first, most patients are NPO and a nasogastric tube is used for suction. The tube is removed in 1 to 2 days as the drainage decreases and fluids and food are slowly introduced. The patient has having MIS does not have an NGT. MIS. I forgot what that is. In collaboration with the ostomy nurse, help the patient adjust and learn required care. The ileostomy begins to drain within 24 hours after surgery at more than 1 liter per day. But be sure that fluids are replaced by adding an additional 500 milliliters or more each day to prevent dehydration. After about a week of high volume output, the drainage slows and becomes thicker. During this period, some patients need Lomotil or Imodium. Oral rehydration therapy, or ORT, can also be used, including Pedialyte and Ceralite. The hospital stay is usually from 4 to 6 days, depending on whether the patient has laparoscopic or open conventional surgery. Patients having MIS, or minimally invasive surgery, that's it. Patients having MIS have less pain and fewer complications from surgery when compared to other surgical patients. Surgery for UC may result in altered body image. However, it may be viewed as positive because the patient will have fewer symptoms and feel more comfortable than before the procedure. Patients have to adjust to having an ostomy before they can resume their pre-surgery activities. Acute pain, chronic pain, planning expected outcomes. The patient with UC will be able to use pain prevention measures such as nutrition changes, use analgesic relief measures, have a decrease in pain to a 2 or 3 on a 1 to 10 pain intensity scale, report changes in pain symptoms to healthcare professionals. Interventions. Pain control requires pharmacologic and non-pharmacologic measures. Physical discomfort can contribute to emotional discomfort. A variety of symptom-reducing interventions and supportive measures is used. Chart 63. The purpose of pain management is alleviation of pain or a reduction in pain to a level of comfort that is acceptable to the patient. Increases in pain may indicate the development of complications such as peritonitis. Assist the patient in reducing or eliminating factors that can cause or increase the pain experience. For example, he or she may benefit from nutrition changes to decrease abdominal discomfort such as cramping and bloating. Antidiarrheal drugs such as Imodium or Lomotil are used to control diarrhea, thus reducing the discomfort. However, they must be used with caution and for a short time because toxic megacolon can develop. Perineal skin can be irritated by contact with loose stools and frequent cleaning. Explain special measures for skin care. Use of medicated wipes is soothing if the rectal area is tender. Figure 64, the creation of an ileanal reservoir. That's just an image there. Okay, so explain special measures for skin care. Use of medicated wipes is soothing if the rectal area is tender or sensitive from the use of toilet tissue. Various manufacturers of ostomies, Hollister, Convatec, produce a 3-product system for skin care that may help prevent and heal perineal skin irritation. Such systems include a skin cleaning solution, a moisturizing and health healing cream, and a petroleum jelly-like barrier that prevents contact of moisture and stool with the skin. Potential for lower GI bleeding, planning expected outcomes. The patient with UC is expected to have a reduction in or cessation of GI bleeding that can occur with the disease. He or she is also expected to remain free of complications of the disease that can cause bleeding, such as perforation. Interventions. The primary nursing responsibility is to monitor the patient closely for signs and symptoms of GI bleeding resulting from the disease or its complications. Monitor stools for blood loss. The blood might be bright red, called frank bleeding, or black and tarry, melena. Monitor hematocrit, hemoglobin, and electrolyte values and assess vital signs. Prolonged, slow bleeding can lead to anemia. Observe for fever, tachycardia, and signs of fluid volume depletion. Changes in mental status may occur, especially among older adults, and may be the first indication of dehydration or anemia. If symptoms of GI bleeding begin, notify the healthcare provider immediately. Blood products may be prescribed for patients with severe anemia. Prepare for the blood transfusion by inserting a large bore IV catheter if it is not already in place. Chapter 42 outlines nursing actions during blood transfusion. Community-based care. Home care management. The patient with UC is managed at home but may require hospitalization during exacerbations. In addition, those who have extraintestinal problems often require ongoing management of joint or skin problems. Home care management focuses on controlling symptoms and monitoring for complications. Instruct the patient about measures to reduce or control abdominal pain, cramping, and diarrhea. Also teach the patient and family about symptoms that should be reported immediately to the healthcare provider, such as fever higher than 101 or 38.3 C, tachycardia, palpitations, and an increase in diarrhea, abdominal pain, or nausea and vomiting. Provide written information and contact numbers for the healthcare provider for patient returning home or transferring to nursing home or traditional care after surgery. Ongoing respiratory care, incision care, ostomy care, and pain management should be continued. Health teaching. Teach the patient about the nature of ulcerative colitis, including its acute episodes, remissions, and symptom management. Also stress that even though the cause is unknown, relapses can be resolved with proper health care. Teach the patient taking immunosuppressive drugs to report signs of possible infection, such as sore throat, to the healthcare provider. Review the drug therapy when drugs should be taken and side effects with the patient and family. There is no special diet for a patient with an ileostomy. However, teach the patient to avoid any foods that cause gas or make the stool thicker. Examples include high-fiber foods like nuts, raw cabbage, corn, celery, apples with peels, and popcorn. The patient needs to learn what foods he or she tolerates best and adjust the diet accordingly. If he or she has undergone a surgical diversion, cooperate with the ostomy nurse to explain and demonstrate required care so that the patient can self-manage. Also teach the importance of including adequate amounts of salt and water in the diet because the ileostomy increases the loss of these substances. Urge the patient to be cautious in situations that lead to heavy sweating or fluid loss, such as strenuous physical activity, high environmental heat, and episodes of diarrhea and vomiting. Chart 64, best practice for patient safety and quality care. Pain control and skin care for patients with inflammatory bowel disease. Abdominal pain, particularly with exacerbations of the disease. Administer analgesics. Assist with frequent positioning. Evaluate foods that increase pain. Perform a comprehensive pain assessment. Observe for signs and symptoms of peritonitis. Evaluate effectiveness of pain management. Teach music therapy, guided imagery. And skin excoriation and or irritation from frequent bowel movements. You want to encourage good skin care with a mild soap and water after each bowel movement. Gently pat the area dry. Evaluate for foods that increase diarrhea. A sitz bath may be of benefit. Apply a thin coat of vitamin A and D ointment or aloe cream. Use medicated wipes instead of tissue. Ensure good fitting, appropriate ostomy supplies. Anti-diarrheal medications may help, but use with caution. Observe for symptoms related to megacolon, fever, leukocytosis, tachycardia, distended abdomen with 3-view abdominal x-ray noting an enlarged colon. Back to the text. Finding the best ostomy pouching system is a major issue for many patients. An effective system is one that protects the skin, contains the effluent or drainage, and reduces odor, if any, remains securely attached to the skin for a dependable period of time. Most patients want an adhesive barrier that will last for 3 to 7 days. The barrier must create a solid seal to prevent the enzymes in the drainage from irritating the skin. Solid barriers are classified as regular wear or extended wear. A person with a high output may want an extended wear barrier. A special cream can be used to help fill any uneven skin surfaces and provide a consistent seal. Pouches are also individualized by the patient. Large pouches can hold more but are heavy when full. Patients also have to consider the costs of various systems and how much their insurance, if they have it, will pay for them. Chart 65 describes the main areas of ileostomy care. A patient with an ileostomy may have many concerns about management at home and about sexual and social adjustments. Considering possible sexual issues helps the patient identify and discuss these concerns with the sex partner. For example, a simple change in positioning during intercourse may alleviate apprehension. Social situations may cause anxiety related to decreased self-esteem and a disturbance in body image. Encourage the patient to discuss possible concerns in addressing and resolving these potentially stressful events. Doggy style? I don't know. Gonna elaborate on that? Okay, healthcare resources. If the patient needs assistance with self-management at home, collaborate with the case manager or a social worker to arrange the services of a home care aide or nurse. A home care nurse can provide assessment and guidance in integrating ostomy care into the patient's lifestyle. The nurse may also teach about wound care, including the monitoring of wound healing, if needed. Chart 66. The patient and family need to know where to purchase ostomy supplies, along with the name, size, and manufacturer's order number. Chart 65. Patient Family Education Guide. Ileostomy Care. Skin Protection. Use of a pectin-based skin barrier to protect your skin from contact with contents from the ostomy. Use skin care products such as skin sealants and ostomy skin creams. If your skin continues to come into contact with ostomy contents, select a product to fill in problem areas and provide an even skin surface. Watch your skin for any irritation or redness. Pouch care. Empty your pouch when it is 1/3 to 1/2 full. Change the pouch during inactive times, such as before meals, before retiring at night, on walking in the morning, and 2 to 4 hours after eating. Change the entire pouch system every 3 to 7 days. Nutrition. Chew food thoroughly. Be cautious of high fiber and high cellulose foods. You may need to eliminate these from the diet if they cause severe problems: diarrhea, constipation, or blockage. Examples include corn, peanuts, coconut, Chinese vegetables, string beans, tough fiber meats, shrimp and lobster, rice, bran, and vegetables with skins, tomatoes, corn, and peas. Drug therapy. Avoid taking enteric-coated and capsule medications. Inform any healthcare provider who is prescribing medications for you that you have an ostomy. Before having prescriptions filled, inform your pharmacist that you have an ostomy. Do not take any laxative or enemas. You should usually have loose stool and should contact a physician if no stool has passed in 6 to 12 hours. Symptoms to watch for. Report any drastic increase or decrease in drainage to your healthcare provider. If stomal swelling, abdominal cramping, or distension occurs, or if ileostomy contents stop draining, then you should remove pouch with faceplate. Lie down, assuming a knee-chest position. Begin abdominal massage. Apply moist towels to the abdomen and drink hot tea. If none of these maneuvers is effective in resuming ileostomy flow, or if abdominal pain is severe, call your healthcare provider right away. And back to the text. Identify the local ostomy support group by contacting the United Ostomy Associations of America, www.uoaa.org. The United Ostomy Association of Canada serves the needs of Canadian patients. A local support group, or the Crohn's and Colitis Foundation of America, ccfa.org, may be helpful in obtaining supplies and providing education for ostomates. Inform the patient and family of available ostomy ambulatory care clinics and ostomy specialists. If the patient agrees, a visit from an ostomate can be continued after discharge to home. Chart 66. Home care assessment. The patient with inflammatory bowel disease. Assess gastrointestinal function and nutritional status, including abdominal cramping or pain, bowel elimination patterns, specifically frequency, characteristics, and amount of stools, and presence or absence of blood in stools, food and fluid intake, including relationship of specific foods to cramping in stools, weight gain or loss, signs and symptoms of dehydration, presence or absence of fever, rectal tenesmus or urgency, bowel sounds, condition of perianal skin, including presence or absence of perianal fistula or abscess. Assess patients' and families' coping skills, including current and ongoing stress level and coping style, availability of support system. Assess home environment, including adequacy and availability of bathroom facilities, opportunities for rest and relaxation. Assess ability to self-manage, therapeutic regimen, including drug therapy, signs and symptoms to report, nutritional therapy, availability of community resources, and importance of follow-up care. Evaluation outcomes. Evaluate the care of the patient with UC on the basis of the identified nursing diagnosis and collaborative problems. Expected outcomes may include that the patient will take personal action to control pain, self-manage the ileostomy, maintain peristomal skin integrity, and demonstrate behaviors that integrate ostomy care into his or her lifestyle. NCLEX examination challenge. A client who is scheduled for an ilioanal reservoir or J-pouch has received pre-operative teaching from the surgeon. Which statement by the client indicates a need for further teaching? I will be able to have sex with my wife even though we might have to adapt a little. I'll really need to watch my intake of dairy products because I'm lactose intolerant. There are some local support groups I can join that can help me get used to this change. I'll have to wear a pouch all the time because my stool will be like liquid paste. I think that's D. Okay, so now on to Crohn's disease. Pathophysiology. Crohn's disease, or CD, is an inflammatory disease of the small intestine, most often, the colon, or both. It can affect the GI tract from the mouth to the anus, but most commonly affects the terminal ileum. CD is a slowly progressive, unpredictable, and recurrent disease with involvement of multiple regions of the intestine with normal sections in between, called skip lesions on x-rays. Unlike UC, Crohn's disease presents as transdermal inflammation that causes a thickened bowel wall. Strictures and deep ulceration or cobblestone appearance also occur, which predispose the patient to developing bowel fistulas. The result is severe diarrhea and malabsorption of vital nutrients. Anemia is common, usually from iron deficiency or malabsorption issues. The complications associated with Crohn's disease are similar to those of UC. Hemorrhage is more common in UC, but it can occur in CD as well. Severe malabsorption by the small intestine is more common in patients with CD because UC does not involve the small bowel at any significant extent. Therefore, patients with CD can become very malnourished and debilitated. Rarely, cancer of the small bowel and colon develop, but usually occurs after the disease has been present for 15 to 20 years. Fistula formation is a common complication of CD, but is rare in UC. Fistulas can occur between segments of the intestine or manifest as cutaneous fistulas or perirectal abscesses. They can also extend from the bowel to other organs and body cavities, such as the bladder or vagina. Some patients develop intestinal obstruction, which at first is secondary to inflammation and edema. Over time, fibrosis and scar tissue develop, and obstruction results from a narrowing of the bowel. Most patients with CD require surgery at some time. Etiology and genetic risk. The exact cause of CD is not known, but it seems to include a combination of genetic, immune, and environmental factors. About 10% to 20% of patients have a positive family history for the disease, but no predominant inheritance pattern is present. The discovery of a mutation in the NOD2 CARD15 gene on chromosome 16 seems to be associated with some patients who have CD. This gene is found in monocytes that normally recognize and destroy bacteria. In the intestines of some patients with CD, the gene cannot respond to bacterial liposaccharide in the cell wall, which results in an overreaction of the immune system. This response leads to uncontrolled inflammation and destruction of intestinal cells. Environmental factors include smoking and bacteria such as mycobacteria that are not part of the normal flora. It was once thought that stress and nutrition play a role in the development of CD, but these factors have not been proven. However, poor nutrition can worsen the patient's symptoms. Incidence and prevalence. More than 1 million people in the United States have the disease. Most have symptoms and are diagnosed as adolescents or young adults. 1 in 500 to 1,000 people have CD. It is more common in people of Ashkenazi Jewish background than in any other group. Patient-centered collaborative care assessment. Physical assessment, clinical manifestations. Crohn's disease is made worse by bacterial infection and inflammation. A detailed history is needed to identify manifestations specific to the disease. Ask about recent unintentional weight loss, the frequency and consistency of stools, the presence of blood in the stool, fever, and abdominal pain. Perform a thorough abdominal examination, assess for manifestations of the disease, and evaluate the patient's nutritional and hydration status. When performing an abdominal assessment, look for findings that are consistent with those in acute appendicitis, e.g., tenderness, guarded movement, a palpable mass in the right lower quadrant. When inspecting the abdomen, assess for distension, masses, or visible peristalsis. Inspection of the perianal area may reveal ulceration, fissures, or fistulas. During auscultation, bowel sounds may be decreased or absent with severe inflammation or obstruction. An increase in high-pitched or rushing sounds may be present over areas of narrowed bowel loops. Muscle guarding, masses, rigidity, or tenderness may be noted on palpation. The clinical presentation of Crohn's disease can vary greatly from person to person. Most patients report diarrhea, abdominal pain, or low-grade fever. Fever is common with fistulas, abscesses, and severe inflammation. If the disease occurs in only the ileum, diarrhea occurs 5 or 6 times per day, often with a soft, loose stool. Steatorrhea, or fatty diarrheal stools is common. Rarely, stools may contain bright red blood. Abdominal pain from the inflammatory process is usually a constant and often located in the right lower quadrant. The patient also may have pain around the umbilicus before and after bowel movements. If the lower colon is diseased, pain is common in both lower abdominal quadrants. Abdominal quadrants. Most patients with Crohn's disease have weight loss. Nutritional problems are the result of increased catabolism from chronic inflammation, anorexia, malabsorption, or self-imposed dietary restrictions. These nutritional problems result in fluid and electrolyte imbalances and protein, iron, vitamin, and mineral deficiencies. The inflammatory bowel changes decrease the small bowel's ability to absorb nutrients, which may be made worse by surgery and fistulas. Be especially alert for manifestations of peritonitis discussed earlier in this chapter, bowel obstruction, and nutritional and fluid imbalances. Early detection of a change in the patient's status helps reduce this life-threatening complication, or these life-threatening complications. Social psychosocial assessment. The patient who has Crohn's disease needs a complete psychosocial assessment. The chronic nature of the problem and the troublesome complications can greatly affect patients and their families. Lifestyle changes are necessary to cope with such a disruptive and painful chronic disease or chronic illness. Assess the patient's coping skill and help identify support systems. Diagnostic assessment. The healthcare provider may request many laboratory studies for patients with Crohn's disease. However, no disease-specific tests are available to confirm the diagnosis except for classic biopsy findings. The results of laboratory tests often indicate the extent and severity of inflammation occurring with the disease. Anemia is common as a result of slow bleeding and poor nutrition. Serum levels of folic acid and cobalamin, or vitamin B12 group, are generally low because of malabsorption, further contributing to anemia. Amino acid malabsorption and protein-losing enteropathy may result in decreased albumin levels. C-reactive protein and ESR may be elevated to indicate inflammation. White blood cells in the urine may show infection or pyuria, which is caused by ureteral obstruction or enterovesical or bowel to bladder fistula. If the severe diarrhea or fistula is present, the patient may have electrolyte losses, particularly potassium and magnesium. X-rays show the narrowing, ulcerations, strictures, and fistulas common with Crohn's disease. An abdominal ultrasound or CT scan may also be performed in acute illness. These tests may be deferred until the risk for perforation lessens. Biopsies obtained via a colonoscopy may verify the diagnosis. Interventions. Management of Crohn's disease is similar to that described on page 1324 in the non-surgical management discussion in the ulcerative colitis section. Non-surgical management. Specific interventions vary with the severity of disease and the complications that are present. Drugs used to manage Crohn's disease are similar to those used in the treatment of ulcerative colitis, except that mesalamine is not very effective for Crohn's disease. See page 1324 in the drug therapy discussion and the ulcerative colitis section. Drug therapy. In addition to drugs used for UC, several other drugs may be used for Crohn's disease. Budesonide or Entocort EC budesonide Entocort EC is a delayed release compound that delivers high local glucocorticoid concentrations to the terminal ileum and right side of the colon for patients with CD. It has little efficacy in UC. Systemic effects are low, but budesonide is tapered slowly if possible. Although glucocorticoids can be effective, sepsis can result from abscesses or fistulas that may be present. These drugs mask the symptoms of infection, therefore they must be used with caution. Monitor the patient closely for signs of infection. Metronidazole or Flagyl, non-vonadazole, Flagyl, 250 to 500 milligrams orally 3 times daily, has been helpful in patients with fistulas. Immunosuppressive therapy has been effective in patients with refractory disease or fistulas. Azathioprine or Imuran, an immunosuppressive agent, 50 milligrams daily for 12 months, may be instituted and then withdrawn. Long-term therapy may be needed in some cases. Methotrexate or MTX may also be given to suppress immune activity. Because a defect in the regulation of inflammation may play a role in the development of Crohn's disease, suppression of a cytokine, specifically tumor necrosis factor, may be useful in decreasing bowel inflammation. Infliximab or Remicade, a monoclonal antibody form of anti-tumor necrosis factor alpha, may be used IV during 8 weeks, or every 8 weeks. The usual dose is 5 milligrams per kilogram for treatment of active CD and fistulas. Adalimumab or Humira is another monoclonal antibody recently approved. Patients who have infection or those with allergies to proteins should not take this drug. Teach the patient to avoid large crowds and anyone who is ill. Remind the patient to report any early signs of infection, including a sore throat or cold. Nutritional therapy. Long-standing nutritional deficits can have severe consequences for the patient with Crohn's disease. Malnutrition can lead to poor fistula and wound healing, loss of lean muscle mass, decreased immune responses, and increased morbidity and mortality. During severe exacerbations of the disease, the patient may be hospitalized to provide bowel rest and nutritional support with total parenteral nutrition, TPN. For less severe exacerbations, an elemental or semi-elemental product such as Vivanex may be prescribed to induce remission. These products are absorbed in the jejunum and therefore permit the distal small intestine and colon to rest. Once remission is achieved, a low-residue diet is usually prescribed. Nutritional supplements such as Ensure or Susticol can be added then to provide nutrients and calories. Teach the patients to avoid GI stimulants, such as beverages and alcohol. Fistula management. Fistulas, abnormal tracts between two or more body areas, are common with acute periods of Crohn's disease. They can be between the bowel and bladder, called introvesical, between two segments of bowel, enteral, or between the skin and bowel, enterocutaneous, or between bowel and vagina, enterovaginal. See Figure 65. The patient with one or more fistulas often has complications such as systemic infections, skin problems, malnutrition, and fluid and electrolyte imbalances. Treatment of the patient with a fistula is complicated and includes nutrition and electrolyte therapy, skin care, and prevention infection. Adequate nutrition and fluid and electrolyte balance are priorities in the care of the patient with the fistula. GI secretions are high in volume and rich in electrolyte and enzymes. The patient is at high risk for malnutrition, dehydration, and hypokalemia, decreased serum potassium. Assess for these complications and collaborate with the healthcare team to manage them. Monitor urinary output. A decrease indicates possible dehydration, which should be treated immediately by providing additional fluids. The patient requires at least 3,000 calories daily to promote healing of the fistula. If he or she cannot take adequate oral fluids and nutrients, total enteral nutrition, or TEN, or TPN may be prescribed. For patients who do not require TEN or TPN, collaborate with the nutritionist to carefully monitor the patient's tolerance to the prescribed diet, assist the patient selecting high-calorie, high-protein, high-vitamin, low-fiber meals, offer enteral supplements such as Ensure and Vivanex, record food intake for accurate calories, provide enteral supplements, and recording intake may be delegated to unlicensed assistive personnel, UAP, under the supervision of the RN. Enzymes in bile in the stool contribute to the problem of skin irritation and excoriation. Skin irritation needs to be prevented. This may be accomplished through the use of skin barriers, pouching systems, and insertion of drains. Skin barriers or dressings are used when the fistula's drainage is less than 100 milliliters in 24 hours. A pouch is used for heavily draining fistulas to reduce the risk for skin irritation and measure the effluent or drainage. However, they are very challenging because of location and drainage amount. Treatment with an antifungal powder applied to the skin around the fistula is often very helpful. For some fistulas, pouching may not be possible because of their location. Drainage may need to be managed using regulated wall suction or a vacuum-assisted closure or VAC device. Continuous low wall suction is attached to a suction catheter in the wound bed of the fistula, not into the fistula tract. These systems are not meant for long-term management. VAC therapy promotes wound healing by secondary intention as it prepares the wound bed for closure, reduces edema, promotes granulation and perfusion, and removes exudate and infectious material. It should not be used for patients who are at risk for bleeding or only for the purpose of drainage containment. Collaborate with the wound or ostomy nurse to select the most appropriate wound management for each patient. Preserving and protecting the skin is the top priority. Wound drainage must never be allowed to be in direct contact with skin without prompt cleaning because the intestinal fluid or enzymes are caustic. Skin breakdown or fungal infection can cause major discomfort for the patient. Patients with fistulas are at high risk for intra-abdominal abscesses and sepsis. Antibiotic therapy is commonly prescribed. Observe for signs of systemic infection or sepsis, such as fever, abdominal pain, or a change in mental status. Complementary and alternative therapies. Other helpful interventions for the patient with CD are those that relax the patient and soothe the GI tract. Such therapies may include naturopathy, herbs, e.g. ginger, acupuncture, hypnotherapy, and Ayurveda, which is a combination of diet, herbs, yoga, breathing exercises. The evidence supporting the use of these substances for CD is lacking, but many patients find them helpful for overall physical and emotional health. Surgical management. Surgery for Crohn's disease is usually performed for those patients who have not improved with medical management or those who have complications from the disease. The patient with a fistula may undergo dissection of the diseased area. Other indications for surgical management include perforation, massive hemorrhage, intestinal obstruction or strictures, abscesses, or cancer. In some cases, the resection can be performed as minimally invasive surgery, MIS, via laparoscopy. Via laparoscopy, which involves one or more small incisions, less pain, quicker surgical recovery, and quicker return to usual lifestyle. Both small bowel resection, usually the ileum, and ileocecal resection can be done during this procedure. Stricturoplasty may be performed for bowel strictures related to Crohn's disease. This procedure increases the bowel diameter. Care before and after each of these surgical procedures is similar to care for patients undergoing other types of abdominal surgery. See Chapter 16 and 18. Community-based care. The discharge care plan for the patient with Crohn's disease is similar to that for the patient with UC in the discussion of community-based care in the ulcerative colitis section. See that. Collaborate with the case manager and wound nurse to help the patient plan self-management. Home care management. The interventions that were started in the hospital to manage the disease should be continued in the home. Reinforce measures to control the disease and related symptoms and manage nutrition. Supplies for wounds and fistula care may be required. The home should be arranged so that the patient has easy access to the bathroom as well as privacy to perform fistula care. Health teaching. The teaching plan for Crohn's disease is similar to that for the patient with UC. Teach the patient about the usual course of the disease, symptoms of complications, and when to notify the healthcare provider. Incorporate drug teaching, including purpose, dose, and side effects, into the teaching plan. In addition to other drugs, vitamin supplements, including monthly vitamin B12 injections, may be needed because of the inability of the ileum to absorb this nutrient. In collaboration with a nutritionist, instruct the patient to follow a low-residue, high-calorie diet and to avoid foods that cause discomfort such as milk, gluten, and other GI stimulants like caffeine. Remind the patient to take rest periods, especially during exacerbations of the disease. If stress appears to increase symptoms of the disease, recommend stress management techniques or counseling. For a long-term follow-up, teach the patient about the increased risk for bowel cancer and the importance of having frequent colonoscopies. If a patient has a fistula, explain and demonstrate fistula care. Provide the opportunity for the patient to practice this care in the hospital. Ideally, he or she should be independent in fistula care before leaving the hospital. However, because of location of the fistula, perirectal or vaginal, or an obese abdomen, assistance may be needed. If this is the case, a family member or a caregiver must learn and practice the care of the case manager (CM) can arrange for home care services. Healthcare resources. The patient discharged to home after undergoing resection and anastomosis may require visits from a home care nurse to assess the surgical wound and monitor for complications. See Chart 16.6. Assess the patient's and family's ability to monitor the progress of fistula healing and to watch for indications of infection and sepsis. Home care nursing visits may also be appropriate for this purpose. A home care aide or other service might be helpful for the patient who cannot meet nutritional needs or who needs help with grocery shopping and meal preparation. In collaboration with the case manager, assist with obtaining the equipment and supplies for fistula care, such as skin barriers and wound drainage bags. A support group sponsored by the United Ostomy Associations of America, UOAA.org, or a local hospital in the community may also be available to help with meeting physician and psychosocial needs. NCLEX Examination Challenge. A client is admitted to the skilled nursing unit for long-term management of an intracutaneous bowel-to-skin fistula that is connected to a vacuum-assisted closure or VAC device. What nursing actions should be implemented when caring for this client? Select all that apply. A. Make sure that the device is functioning properly. B. Protect the skin from irritating damage. C. Use the device every other day as prescribed. D. Teach the family how to use the device. E. Measure and record all fistula drainage. And F. Assess the wound for healing and document. Okay. Now, diverticular disease. Diverticula are pouch-like herniations of the mucosa through the muscular wall of any portion of the gut, but most commonly the colon. Diverticulosis is the presence of many abnormal pouch-like herniations or diverticula in the wall of the intestine. Diverticulitis is the inflammation of one or more diverticula. Pathophysiology. Diverticula can occur in any part of the small or large intestine, but usually occur in the sigmoid colon. Figure 67. The muscle of the colon hypertrophies, thickens, and becomes rigid, and herniation of the mucosal and submucosa through the colon wall is seen. Diverticula seems to occur at points of weakness in the intestinal wall, often at areas where blood vessels interrupt the muscle layer. Muscle weakness develops as part of the aging process or as a result of a lack of fiber in the diet. Without inflammation, diverticula cause few problems. If undigested food or bacteria become trapped in the diverticulum, however, blood supply to that area is reduced. Bacteria invade the diverticulum, resulting in diverticulitis, which then can perforate and develop a local abscess. A perforated diverticulum can progress into an intra-abdominal perforation with peritonitis, inflammation of the peritoneum. Bleeding from diverticula can range from minor local bleeding to massive hemorrhage. Minor bleeding is often due to inflammation in areas of new blood vessel tissue at the base of the diverticulum. Hemorrhage can result when a blood vessel breaks down within a diverticulum. Inflammation from recurrent diverticulitis can lead to scarring and narrowing of the bowel lumen, which may then result in obstruction. Inflammation can also result in fistulas to other organs such as the bladder and the vagina. High intraluminal pressure forces the formation of a pouch in the weakened area of the mucosa. Frequently near blood vessels. Diets low in cereal fiber that cause less bulky stool and constipation have been implicated in the formation of diverticula. Retained undigested food in diverticula is suggested to be one cause of diverticulitis. The retained food reduces blood flow to that area and makes bacterial invasion of the sac easier. The exact incidence of diverticulosis is unknown, but millions of people are affected by the problem. Diverticulitis is found in 1/2 of adults older than 60 years, with more men than women affected. The cause for this difference is not known. Although diverticulosis is common, only 1 of 5 people with the disease has noticeable symptoms. Patient-centered collaborative care assessment. The patient with diverticulosis usually has no symptoms, unless pain or bleeding develops. The condition may go undiagnosed. Occasionally, diverticulosis will cause symptoms. For the patient with uncomplicated diverticulosis, ask about intermittent pain in the left lower quadrant and a history of constipation. If diverticulitis is suspected, ask about a history of low-grade fever, nausea, and abdominal pain. Inquire about recent bowel elimination patterns such as constipation may develop as a result of intestinal inflammation. Also ask about any bleeding from the rectum. On physical examination, uncomplicated diverticulosis may produce no clinical manifestations. Occasionally, tenderness occurs on abdominal palpation. The patient with diverticulitis may have abdominal pain, most often localized to the left lower quadrant. It is intermittent at first but becomes progressively steady. Occasionally, pain may be just above the pubic bone or may occur on one side. Abdominal pain is generalized if peritonitis has occurred. Nausea and vomiting are common. The patient's temperature is elevated, ranging from low-grade fever to 101, 38.3 Celsius. Chills may be present. Often an increased heart rate or tachycardia occurs with fever. Considerations for older adults. The first sign of peritonitis in older adults may be a sudden change in mental status, e.g. acute confusion. For those who have dementia, the confusion worsens. Fever and chills may not be present. On examination of the abdomen, observe for distension. The patient may report tenderness over the involved area. The colon may be palpable. Localized muscle spasm, guarded movement, and rebound tenderness may be present with peritoneal irritation. If generalized peritonitis is present, profound guarding occurs. Rebound tenderness is more widespread, and sepsis, hypotension, and hypovolemic shock can occur. If the perforated diverticulum is close to the rectum, the health care provider may palpate a tender mass during the rectal examination. Blood pressure checks may show orthostatic changes. If bleeding is massive, the patient may have hypotension and dehydration that result in shock. For the patient with uncomplicated diverticulosis, laboratory studies are not indicated. The patient with diverticulitis, however, has an elevated white blood cell count, decreased hematocrit, and hemoglobin values are common if chronic or severe bleeding occurs. Stool tests for occult blood, if requested, are sometimes positive. Urinalysis may show a few red blood cells in the left ureter if the left ureter is near a perforated diverticulum. X-rays of the intestinal tract with barium contrast may show diverticula. An upper GI series shows diverticula of the small intestine, and barium enema shows diverticula of the large intestine. Diverticula are most often diagnosed during routine colonoscopy. The patient with diverticulitis usually does not undergo a barium enema procedure in the acute phase of the illness because of the risk for rupture of the inflamed diverticulum. A barium enema may be completed after the patient has been treated with antibiotics and the inflammation has resolved. A flat plate film of the abdomen is done to evaluate for free air and fluid indicating perforation. A CT scan may be performed to diagnose an abscess or thickening of the bowel related to diverticulitis. Abdominal ultrasonography, a non-invasive test, may also reveal bowel thickening or an abscess. The physician may recommend a colonoscopy 4 to 8 weeks after the acute phase of the illness to rule out a tumor in the large intestine, particularly if the patient has rectal bleeding. Interventions. Patients are managed on an ambulatory care basis if the symptoms are mild. Monitor the patient for any prolonged or increased fever, abdominal pain, or blood in the stool. The patient with moderate to severe diverticulitis may be hospitalized. Manifestations suggesting the need for admission are a temperature higher than 101, 38.3, persistent and severe abdominal pain for more than 3 days, and or lower GI bleeding. Non-surgical management. Combination of drug and nutrition therapy with rest to decrease inflammation and improve tissue perfusion is used. Broad-spectrum antimicrobial drugs such as metronidazole or Flagyl plus trimethoprim or sulfamethoxazole or Bactrim or Cipro are prescribed. A mild analgesic may be given for pain. Chart 67 lists key issues regarding older adults with diverticulitis. The patient with more severe pain is admitted to the hospital for IV fluids to correct dehydration and IV drug therapy. Anticholinergics may reduce intestinal hypermotility, although they should be avoided for older adults. For patients with moderate to severe diverticulitis, an opioid analgesic such as meperidine hydrochloride or Demerol or morphine sulfate can alleviate pain. Meperidine is not used for older adults because of its adverse effects. In some agencies, this drug is no longer used for any patient. Laxatives and enemas are avoided because they increase intestinal motility. Assess the patient on an ongoing basis for manifestations of fluid and electrolyte imbalance. Teach the patient to rest during the acute phase of illness. Remind him or her to refrain from lifting, straining, coughing, or bending to avoid an increase in intra-abdominal pressure, which can result in perforation of the diverticulum. Nutrition therapy should be restricted to low-fiber or clear liquids based on symptoms. The patient with more severe symptoms is NPO, and nasogastric tube is inserted if nausea, vomiting, or abdominal distension is severe. Infuse IV fluids as prescribed for hydration. In collaboration with the nutritionist, the patient increases dietary intake slowly as symptoms subside. When inflammation has resolved and bowel function returns to normal, a fiber-containing diet is introduced gradually. Surgical management. Diverticulitis can result in rupture of the diverticulum with peritonitis, pelvic abscess, bowel obstruction, fistula, persistent fever or pain, or uncontrolled bleeding. The surgeon performs emergency surgery if peritonitis, bowel obstruction, or pelvic abscess is present. Colon resection with or without a colostomy is the most common surgical procedure for patients with diverticular disease. The surgeon removes the portion that is inflamed or diseased and, if possible, creates an anastomosis of the colon to restore patency. Inflammation and infection, however, may prevent an anastomosis. If this is the case, the surgeon may perform a colostomy. See Figure 62b for appearance of a stoma. Some patients may have colostomy closure and anastomosis after the bowel has been allowed to rest for 3 to 6 months. Chart 67. Nursing focus on the older adult. Diverticulitis. Provide antibiotics, analgesics, and anticholinergics as prescribed. Observe older patients carefully for side effects of these drugs, especially confusion or increased confusion, urinary retention or failure, and orthostatic hypotension. Do not give laxatives or enemas. Teach the patient and the family about the importance of avoiding these measures. Encourage the patient to rest and to avoid activities that may increase intra-abdominal pressure, such as straining and bending. While diverticulitis is active, provide a low-fiber diet. When the inflammation resolves, provide a high-fiber diet. Teach the patient and family about these diets and when they are appropriate. Because older patients do not always experience the typical pain or fever expected, observe carefully for other signs of active disease, such as a sudden change in mental status. Perform frequent abdominal assessments to determine distension and tenderness on palpation. Check stools for occult or frank bleeding. Preoperative care. Preparation of the patient for surgery depends on the severity of the condition and whether it is an emergency or is performed a few weeks after the acute stage. The surgeon informs the patient whether a temporary or permanent colostomy might be required. If the patient is not in the acute stage of diverticulitis, a thorough bowel preparation may be given, consisting of enemas and laxatives daily for 1 to 2 days before surgery. Because of the risk for perforation, however, the surgeon usually does not require an aggressive bowel preparation. If the patient has an acute inflamed diverticulum or persistent fever and abdominal pain, the bowel preparation is withheld. The value of preoperative bowel preparation, or bowel prep, for any patient having abdominal surgery is being questioned. For years, it was thought that this procedure helped prevent contamination during surgery and sepsis. However, recent studies have shown no difference in clinical outcomes when patients did not have a bowel prep. Also, this intervention is very uncomfortable and unpleasant for the patient having surgery. For patients with acute inflammation, a low-fiber diet may be implemented for several days, followed by a clear liquid diet for the day or evening before surgery. Preoperative teaching may include information about the possible need for a colostomy. If a colostomy is a possible outcome, collaborate with the certified wound, ostomy, and continence nurse, CWOCN, or an enterostomal therapist, ET, or ostomy nurse, to describe its function and care. Operative procedures. The patient may have one or two surgical approaches: open, conventional approach, or minimally invasive surgery, MIS, via a laparoscopy. The advantage of MIS is that patients are discharged from the hospital quicker, have less pain after surgery, and have fewer postoperative complications. They are able to resume normal activities much faster than patients having the traditional surgery. Postoperative care. The nursing care for patients during the first few days after a colon resection for diverticulitis is the same as that for any patient undergoing abdominal surgery. The patient may have a drain in place at the abdominal incision site for several days. If a colostomy has been performed, the stoma may be covered with a petroleum gauze dressing because the colostomy does not drain for about 2 days, or a colostomy bag may be placed over the stoma. If the stoma is visible, monitor for color and integrity. The stoma should be pinkish to cherry red without retraction or prolapse into the abdomen. The patient is NPO with an NG tube until peristalsis returns, about 2 to 3 days. Clear liquids are then introduced slowly. Gradually, the diet is to solids depending on the return of peristalsis and bowel function. Patients who had laparoscopic surgery do not usually have an NGT. Most patients with a colostomy for diverticulitis have a sigmoid colostomy because the sigmoid colon is the most common site of diverticulitis. Drainage from a sigmoid colostomy at first consists of loose stool, but eventually the stool becomes formed. A tight seal around the stoma is essential to avoid contact of feces with the skin. Colostomy care is detailed in Chapter 59. Give the patient an opportunity to express feelings about the ostomy. Discuss these feelings with the patient, reinforcing that anger and depression are normal responses. When he or she is physically able, encourage the patient to look at the stoma and touch the pouching system. Collaborate with the ostomy nurse to teach the patient how to self-manage ostomy care. Community-based care. The length of stay for patients hospitalized for diverticulitis ranges from 2 to 4 or more days, depending on the response to treatment and the need for surgery. Discharge plans vary according to the treatment. For the patient with diverticulitis who has responded to medical treatment, home care focuses on proper nutrition, assess the patient's ability to obtain and prepare the recommended high-fiber foods. The patient who has surgical intervention has the added responsibilities of incision care and possibly colostomy care with temporary limitations placed on activities. Healthcare teaching. All patients with diverticular disease need education regarding a high-fiber diet. Collaborate with the nutritionist to encourage the patient with diverticulosis to eat a diet high in cellulose and hemicellulose types of fiber. These substances can be found in wheat bran, whole grain breads, and cereals. Teach the patient to eat at least 25 to 35 grams of fiber per day. Fresh fruits and vegetables with high fiber content are added to add bulk to stools. If not accustomed to eating high-fiber foods, teach the patient to add them to the diet gradually to avoid flatulence and abdominal cramping. If he or she cannot tolerate the recommended fiber requirements, a bulk-forming laxative, such as psyllium hydrophilic muciloid or Metamucil, can be taken to increase fecal size and consistency. Teach the patient to drink plenty of fluids to help prevent bloating that may occur with a high-fiber diet. Alcohol should be avoided because it irritates the bowel. Foods containing seeds or indigestible material that may block a diverticulum, such as nuts, corn, popcorn, cucumbers, tomatoes, figs, and strawberries may be eliminated, but this is controversial. Some clinicians do not believe this is necessary as long as the patient incorporates a high-fiber cereal diet or supplement. Teach the patient that dietary fat intake should not exceed 30% of the total dietary caloric intake. Reinforce the teaching performed by the nutritionist. Teach the patient to avoid all fiber when symptoms of diverticulitis are present, because high-fiber foods are then irritating. As it resolves, fiber can gradually be added until the progression to a high-fiber diet is once again obtained. The patient who has undergone surgery is usually taking solid food by the time of discharge from the hospital. The patient who has had abdominal surgery needs oral and written instructions on incision care and the signs and symptoms to report to the healthcare provider. Provide instructions on colostomy care as needed. Encourage the patient to express concerns about body image. Allow time and address the sexual concerns regarding the changed body image. Instruct the patient with any type of diverticular disease orally in writing about the manifestations of acute diverticulitis, including fever, abdominal pain, and bloody mahogany or tarry stools. Advise patients to avoid the use of laxatives other than bulk-forming types and enemas. Reassure them that this disorder should not cause problems if a proper diet is followed. Healthcare resources. In collaboration with the case manager, arrange for a home care nurse if needed to assess wound healing and proper functioning of the ostomy and the appliance. If the patient is interested, allow for a visit from an ostomy volunteer or ostomate or an ostomy nurse. For information about other community resources, remind the patient to contact the United Ostomy Association of America, UOAA.org. Decision-making challenge. Coordination of care. A 50-year-old woman had her first screening colonoscopy. She has had no symptoms, but her father had colon cancer at age 58 years. His cancer was surgically removed, but he did not require any other treatment. Her father is still alive and well with no recurrence. The patient's colonoscopy showed moderate to severe diverticulosis in the sigmoid colon and mild diverticulitis in the descending colon. She previously had 2 benign polyps completely removed, one from the cecum and one from the transverse colon. She takes 1 oral fiber supplement capsule daily, a proton pump inhibitor for GERD, and an ACE inhibitor for hypertension. 1. How would you explain the diverticulosis versus diverticulitis to this patient? Is this patient a candidate for antimicrobial therapy? Why or why not? What nutritional modifications and restrictions should follow and why? Keep her GERD in mind as well. And what other health teaching does she need? What healthcare team members might be involved in her care? Anal disorders. Anorectal abscess. Pathophysiology. Anorectal abscess is a localized area of induration and pus caused by inflammation of the soft tissue near the rectum or anus. It is most often the result of obstruction of the ducts of glands in the anorectal region. Feces, foreign bodies, or trauma can be the cause of the obstruction and stasis, leading to infection that spreads into nearby tissues. Most abscesses begin as a pocket of infection in an anal crypt. Okay, rectal pain is often the first symptom. There may be no other manifestations at first, but local swelling, redness, and tenderness to touch are present within a few days after the onset of pain. If the abscess becomes chronic, discharge, bleeding, and pruritus or itching pruritus may exist. Fever occurs if large abscesses are present. Patient-centered collaborative care. Anorectal abscesses are managed by surgical incision and drainage. The physician can often incise or surgically remove simple perianal and ischiorectal abscesses using a local anesthetic. For patients with more extensive abscesses, a regional or general anesthetic may be needed. Systemic antibiotics are given only for patients who are immunocompromised, are diabetic, have valvular disease or prosthetic valve, or are obese. Incision and drainage, I&D, for these patients after antibiotic therapy. Nursing interventions are focused on comfort and helping the patient maintain optimal personal hygiene. Chart 68. Encourage the use of warm sitz bath, analgesics, bulk producing agents, and stool softeners after the surgery until healing occurs. Stress the importance of good perineal hygiene after all bowel movements and the maintenance of a regular bowel pattern with a high fiber diet. Patients are often embarrassed about having anal problems. Provide privacy and maintain the patient's dignity during the examination and treatment. Anal fissure. An anal fissure is a tear in the anal lining. This common problem can cause much discomfort and disability. Small fissures occur with straining to have a stool, such as with diarrhea or constipation. Larger, deeper fissures may occur as a result of another disorder, e.g. Crohn's disease, tuberculosis, leukemia, and neoplasm, or from trauma, e.g. from a foreign body, rough anal intercourse, or pararectal surgery. An acute anal fissure is superficial and usually resolves on its own or heals quickly with conservative treatment. Chronic fissures recur and surgical treatment may be needed. Pain during and after defecation and bright red blood in the stool are the most common symptoms. Other manifestations include pruritus, urinary frequency or retention, dysuria, and dyspareunia, or painful intercourse. Ouch. Chart 68. Best practice for patient safety and quality. Promoting perineal comfort. Keep the perineal area clean with mild soap. Pat the perineal area dry instead of rubbing it. Provide warm sitz bath or apply warm compresses to the area. If the area is acutely inflamed, apply cold packs. Provide a chair cushion for the seated patient. For the older or debilitated patient, monitor the skin carefully to prevent pressure sores. Use the absorbent pad for drainage, if any, and change them often. Use pre-moistened wipes for cleaning and cleaning the perineal area after a bowel movement. Use witch hazel wipes, e.g. Tucks, to relieve pain. Give bulk forming agents such as psyllium mucoid or Metamucil as prescribed to reduce pain associated with defecation. Apply a topical anesthetic cream to the perineal area as prescribed. Give oral analgesics as prescribed for pain relief. Do not administer enemas or give potent laxatives. The diagnosis is made by stretching and inspecting the perianal skin. If the patient is having pain at the time of the examination, diagnostic testing is usually limited to inspection. If he or she is not in severe pain, a digital examination and possibly a sigmoidoscopy are performed. When painless or multiple fissures are present, a colonoscopy may be performed to rule out any inflammatory bowel disorder. Management of an acute fissure is usually aimed at local pain relief and softening of stools to reduce trauma to the area. Teach the patient to use warm sitz baths, analgesics, and bulk-producing agents, e.g. psyllium hydrophilic mucoid or Metamucil, to help minimize the pain from defecation. Topical anti-inflammatory agents, hydrocortisone creams and suppositories, or opiate suppositories, opium and belladonna suppositories, are helpful if spasms are severe. Explain the pain control measures to the patient. Remind him or her to notify the healthcare provider if pain is not relieved within a few days. If fissures do not respond to this management within several days to weeks, surgical repair under a local anesthetic may be needed. Teach the patient to report any drainage or bleeding from the rectum to the healthcare provider. Anal fistula. An anal fistula, or fistula in ano, is an abnormal tract leading from the anal canal to the perianal skin. Most anal fistulas result from anorectal abscesses, which are caused by obstruction of anal glands. See anorectal abscess 1337, just talked about. Fistulas can also occur with tuberculosis, Crohn's disease, or cancer. Intermittent discharge is usually noted over the perianal area. The patient with an anal fistula has pruritus or itching, purulent discharge, and tenderness or pain that is worsened by bowel movements. A proctoscope may be used to identify the source of symptoms and to locate the fistula. Because fistulas do not heal spontaneously, surgery is necessary. To perform a fistulotomy, the surgeon opens the tissue over the tract and scrapes the base. The incision site then heals by secondary intention. For a fistula higher in the anus, a special surgical technique is used to preserve important sphincters. After surgery, instruct the patient about sitz baths, analgesics, and the use of bulk-producing agents or stool softeners to reduce pain. Parasitic infection. Pathophysiology. Parasites can enter and invade the GI tract and cause infections. They commonly enter through the mouth or oral fecal transmission from contaminated food or water, oral anal sexual practices, or contact with feces from a contaminated person. Common parasites that cause infection in humans are Entamoeba histolytica, which causes ambiasis or ambic dysentery. There's Giardia lamblia, which causes giardiasis, and cryptosporidium. Hand washing is the best way to prevent the spread of parasitic infections. Entamoeba histolytica. Humans are the only known hosts for E. histolytica, also known as ambiasis. Amoebiasis. Okay, amoebiasis. There we go. Amoebiasis. This organism occurs in cysts and trophozoites, or sporozoan parasites. Trophozoites die rapidly after they leave the body in stool. Cysts, however, can remain alive in the right type of environment for weeks or months. Humans who eliminate cysts are infectious. Flies can spread the cysts, and the problem is more common in areas that use human excrement for fertilizer. Okay, yuck. Amoebiasis occurs worldwide, but is most common in tropical areas. Prevalence rates are as high in areas with poor sanitation, crowding, and poor nutrition. Amoebiasis causes tens of thousands of deaths annually worldwide. The disease causes less severe symptoms and often goes undiagnosed in temperate climates. E. histolytica either feeds on bacteria in the intestine or invades and ulcerates the mucosa of the large intestine. The parasite can be limited to the GI tract, intestinal amoebiasis, or it can extend outside the intestines, extraintestinal amoebiasis. People can have intestinal amoebiasis without having any symptoms, or symptoms can range from mild to severe. Giardia lamblia. G. lamblia is a protozoal parasite that causes superficial invasion, destruction, and inflammation of the mucosa in the small intestine. Like E. histolytica, G. lamblia has a trophozoite and cysts form, which is the usual form of transmission. Humans are hosts to this organism, but beavers and dogs may be reservoirs for infection. Giardiasis is a well-recognized problem in travelers, campers, and immunosuppressed patients. Modes of transmission are similar to those of amoebiasis in the United States. However, giardiasis is much more prevalent and is the most common parasitic infection. Giardiasis affects only the intestinal system, causing acute diarrhea, chronic diarrhea, or malabsorption syndrome. The acute phase usually is self-limiting, lasting days or weeks. The chronic phase can last for years. Diarrhea is usually mild in both forms, but it can be severe. As stools increase in frequency, they become more watery, greasy, frothy, and malodorous with mucus. Weight loss and weakness are also common. Malabsorption can occur with diarrhea that continues for longer than 3 weeks. Manifestations result from malabsorption of fat, protein, vitamin B12, and lactase deficiency. Cryptosporidium. Cryptosporidium is manifested by diarrhea. This infection occurs most commonly in immunosuppressed patients, particularly those with HIV. It can also occur in children and older adults from contaminated swimming pools. See Chapter 21 for discussion of HIV infection. Patient-centered collaborative care assessment. A thorough history can help determine potential sources of exposure to parasitic infection. A history of travel to parts of the world where such infections are prevalent increases suspicion for infection with parasites. GI symptoms related to travel may be delayed as long as 1 to 2 weeks after the return home. Immigrants or newcomers may have the infection upon entering a new country. A nutrition history is especially helpful if several people in a group become ill. Common water supplies or bodies of water may be infected with Giardia or Cryptosporidium. Trichinosis should be considered if the patient has eaten pork products. Mild to moderate E. histolytica infestation causes the daily passage of severe, strongly foul-smelling stools, possibly with mucus but without blood, accompanied by abdominal cramping, flatulence, fatigue, and weight loss. The infected patient usually experiences remissions and recurrences. Severe amoebic dysentery is manifested by frequent, more liquid and foul-smelling stools with mucus and blood. Fever up to 104 or 40 Celsius, tenesmus or feeling the urge to defecate, generalized abdominal tenderness, and vomiting can also occur. The ulcerations of invading amoebiasis that occur in the colon can cause pain, bleeding, and an obstruction. Ulcerations can also occur in the rectum, resulting in formed stool with blood. Complications are rare but include appendicitis and bowel perforation. Extraintestinal amoebiasis can occur without symptoms of intestinal infection. The most common form is amoebic liver abscess, which causes symptoms of fever, pain, and an enlarged liver. The abscess can rupture and death can result if the infection and complications are not treated. The diagnosis of amoebiasis is made by examining the stool for parasites. Because E. histolytica is difficult to detect, serial stool examinations are needed if the disease is suspected. The use of sigmoidoscopy may detect ulcerations in the rectum or colon. Exudate obtained during sigmoidoscopic examination is studied for the parasite. The white blood cell count can be as high as 20,000 mm3 when severe dysentery is present. The diagnosis of giardiasis is also confirmed by the presence of parasites in the stool. Because organisms may not be detected for at least 1 week after symptoms appear, multiple stool samples should be examined. Interventions. Treatment for all types of amoebiasis involve the use of amoebicide drugs. metronidazole or Flagyl or novanidazole, and dilozanide furoate or entamide, or dilozanide furoate and tetracycline hydrochloride or sumacin, followed by chloroquine, are commonly prescribed. The patient with severe dysentery requires IV fluid replacements and possibly opiates, such as diphenoxylate hydrochloride and atropine sulfate or Lomotil, to control bowel motility. The patient with extraintestinal amoebiasis or severe dehydration is hospitalized, especially the older adult. The patient with asymptomatic mild or moderate disease is treated with drug therapy on an ambulatory care basis. Therapy effectiveness is based on the examination of at least 3 stools at 2 to 3 day intervals, starting 2 to 4 weeks after drug therapy has been completed. Teach patients the importance of keeping their follow-up appointments and taking all drugs as prescribed. Treatment for giardiasis is drug therapy. Metronidazole is the drug of choice, 250 milligrams orally 3 times daily for 5 days. Tinidazole or Fasogen can be used as an alternative. Stools are examined 2 weeks after treatment to assess for drug effectiveness. Explain modes of transmission and means to avoid the spread of infection and recurrent contact with parasitic organisms. Inform the patient that the infection can be transmitted to others until amoebicides effectively kill the parasites. Teach the patient to avoid contact with stool, keep toilet areas clean, wash hands meticulously with an antimicrobial soap after bowel movements, maintain good personal hygiene by bathing or showering daily, avoid stool from dogs and beavers. Don't touch that beaver poop. Damn it. Advise the patient to avoid sexual practices that allow rectal contact until drug therapy is completed. All households and sexual partners should have stool examinations for parasites. If the water supply is suspected as a source, a sample is obtained and sent for analysis. Multiple infections are common in households, often as a result of contaminated water supplies. Well water and water from areas with inadequate or no filtration equipment can be sources of contamination. Infection with Cryptosporidium is usually self-limiting in people who have normal immune function. Drug therapy for patients who are immunosuppressed may include paromomycin or paramycin, an aminoglycoside antibiotic, 500 to 750 milligrams orally 4 times daily. Teach patients that this drug can cause dizziness. Oh boy, my favorite, the worms. Helminthic infestation. Helminths are worm-like animals that are often parasitic and capable of causing infectious disease in humans. There are many species of helminths, which are divided into the general categories of roundworms or nematodes, flukes or trematodes, and tapeworms or cestodes. Roundworms, flukes, and tapeworms. Helminths can cause various degrees of GI problems in humans. Most often they enter the human body through the skin or via the oral route with ingestion of contaminated food or water. Some gain access to the body via insects, such as flies and mosquitoes, occurring mostly in tropical areas, and are not discussed here. Flukes, or trematodes, which are passed to humans via snail-contaminated water, are also limited to tropical and subtropical areas outside the United States and Canada, and are not discussed here. However, travel to or from these areas may result in infestation with flukes. Roundworms. Roundworms cause most of the helminthic infections in the United States and worldwide. These infections include enterobiasis, trichinosis, hookworms, and tapeworms. Enterobiasis, or pinworm infection, is caused by Enterobiasis vermicularis, and is the most common helminthic infection in the United States. It is transmitted by oral intake of contaminated foods or drink. Manifestations of infection include intense perianal pruritus or itching, especially at night, vaginitis, insomnia, and restlessness. The patient may have vague GI symptoms such as abdominal pain, nausea, vomiting, and diarrhea. However, infected people have no symptoms. Diagnosis is made when eggs of the helminths are found on the perianal skin or on cellulose tape that has been applied to the perianal skin. You just put a piece of tape on there and find them worms. They come out at night and feed. Treatment of enterobiasis includes meticulous hand washing after defecation and before meals to prevent spread of the worms to others. Drug therapy is indicated for all patients with symptoms and for some who are infected but are not symptomatic. Household members of an infected patient may be treated with drug therapy even if they have no symptoms. Pyrantel paomate or anti-minth combatrin or mebendazole or Vermox is given orally in one dose, repeated at 2 and 4 weeks. Infection with pinworms is curable and does not usually lead to complications. However, recurrences are common. Trichinosis. Trichinosis is caused by roundworms. The incidence in the United States is very low, but many mild or asymptomatic cases go undiagnosed. Trichinosis spiralis, which lives in the intestine of humans, pigs, bears, and rats, causes trichinosis. The organism is usually transmitted to people who eat undercooked pork or pork products. Ingestion of other meats, such as ground beef, can also cause infection if a meat grinder has been used for both beef and pork and the meat is undercooked. After ingestion, the larvae are released by the action of acid and enzymes in the digestive tract. Incubation is 12 hours to 28 days after ingestion. Manifestations range from none to severe. Death rarely results. During the first week after infection, diarrhea results from the invasion of the gut by large numbers of parasites. Abdominal pain, nausea, and vomiting may follow. During the second week, the larvae begin to invade the muscle, starting a hypersensitivity reaction with fever, edema of the face and around the eyes, and subjunctival hemorrhage. Occasionally, a rash or dyspnea develops. 2 to 3 weeks after infection, symptoms of myositis, malaise, and muscle weakness develop, particularly in the lower back, neck, jaw, biceps, and muscle controlling eye movement. Vague muscle pain and malaise continue into the recovery phase, which can last several months. A diagnosis of trichinosis is confirmed by a history of ingestion of raw or undercooked meat, white blood cell, and eosinophil count are elevated for 2 weeks after meat is ingested. Biopsy of skeletal muscle shows larvae of the trichinella organism. Worms are rarely seen in feces. The patient is treated with the oral midazolam or Vermox. During the stage of muscle invasion, hospitalization for high doses of corticosteroids may be required. Hookworms. Hookworms are also roundworms. They differ from pinworms and trichinella in that they enter the human body through the skin. Hookworm disease is caused by either ancylostoma duodenale or Necator americanus. Hookworms infect a quarter of the world's population, but the disease is rare in areas outside the tropics or in areas with little rain. However, as people travel around the world or enter the United States as newcomers, these diseases may become more common throughout the world. Worms are infective outside the body in warm, moist soil for up to 1 week. Infection occurs when larvae penetrate through the skin. The organism can travel to the lungs via the respiratory tree to the pharynx and the mouth, where they are swallowed and enter the GI tract. Hookworms probably also enter the GI tract when a person ingests contaminated food. Early symptoms of hookworm disease include an itchy, red, raised, blister-like inflammation of the skin. Infection in the GI tract may produce no symptoms or may cause anorexia, diarrhea, or mild abdominal and epigastric discomfort. Bleeding and anemia may occur when hookworms suck blood at sites of attachment in the GI tract. If blood loss is severe, the patient may have symptoms of anemia such as pallor, hair thinning, deformed nails, pica, and the shortness of breath. Diagnosis of hookworm infection is based on the presence of ova or eggs in the feces. Occult blood is often present in the stool. The patient may also have anemia with low hemoglobin and hematocrit levels or a low serum iron level and high iron binding capacity. WBC and eosinophil counts are elevated. All patients with symptoms receive iron therapy and a diet high in protein and vitamins for at least 3 months after anemia is corrected. Pyrantel pamoate or anti-minth or mebendazole or Vermox is prescribed for a complete recovery. Severe hookworm disease can cause malabsorption and protein loss, requiring nutritional supports in addition to other treatments. Tapeworms. 5 types of tapeworms. Cestodes may infect humans. Tapeworms found in cattle, fish, dogs, pigs, and rodents. Tapeworm infections generally cause either no symptoms or only occasional GI upset such as nausea, diarrhea, or abdominal pain. The diagnosis of tapeworm infestation is made by laboratory examination of eggs found in the stool, test of stool for ova and parasites. Infection of tapeworms occurs when a person eats undercooked beef, raw fish, or other contaminated food or water, or accidentally swallows infected lice or fleas from dogs. People can also accidentally eat arthropods, such as cockroaches, in stored foods or cereals. God, barf. Treatment is usually with praziquantel or biltricide, 10 milligrams per kilogram, except for Hymenolepsis nana, or dwarf tapeworm. in which case the dose is 25 milligrams per kilogram in a single dose, and may be repeated 1 week later. Beef tapeworm can be treated with albendazole or albenza 400 milligrams daily for 3 days, and niclosamide or nicloside 500 milligram chewable tablet is sometimes used for dog tapeworm infestations. When caring for all patients with helminths, follow standard precautions when in contact with any stool. Teach the patient to wash the hands after defecating and before eating. Prevention methods include avoiding eating undercooked beef, fish, or pork, and drinking water that might be contaminated. Other prevention strategies include keeping the mouth closed while petting dogs after touching any animal. Stored foods should be kept tightly closed to avoid contamination by cockroaches and other insects. Food poisoning. Foodborne illnesses are a common problem in the United States and all other parts of the world and can cause death. The problem results when a person ingests infectious organisms in food. Unlike gastroenteritis, food poisoning is not directly communicable from person to person, and incubation periods are shorter. However, like gastroenteritis, it causes diarrhea, nausea, and vomiting. Food poisoning can be differentiated from gastroenteritis by obtaining a thorough history of common food intake in patients who have common symptoms of acute diarrhea, nausea, and vomiting. Food poisoning is caused by over 250 pathogens. Examples include gram-negative salmonella, Staphylococcus aureus, E. coli, and botulism. Table 66. Table 66 lists more information about these microbes. All cases of botulism and salmonellosis need to be reported to the local health department. Cases of Staphylococcus and E. coli food poisoning are reported if epidemic outbreaks occur. Salmonellosis. Salmonellosis is a bacterial infection caused by the Salmonella organism and infects 40,000 people each year in the United States. Salmonella bacteria live in the intestinal tract of humans and animals. They can be transmitted by the 5 F's: flies, fingers, food, feces, and fomites. Incubation is 8 to 48 hours after the person has ingested the contaminated food or liquid. The most common source. Foods that are most commonly contaminated are eggs, beef, poultry, and green leafy vegetables, e.g. spinach. In 2008, contaminated jalapeno peppers from Mexico caused salmonella infection in hundreds of people in the United States. Although usually last for 4 to 7 days, most people have fever, nausea, vomiting, cramping, abdominal pain, and foul-smelling diarrhea, which may be bloody. In some patients, fever is very high. Salmonellosis is usually self-limiting, but bacteremia that infects the joints or bones may occur later in the disease process. Diagnosis is made by stool culture. Treatment is symptomatic. If bacteremia occurs, antibiotics such as ampicillin or ciprofloxacin or Cipro are prescribed. Unfortunately, some salmonella bacteria have become resistant to antibiotics because of the use of these drugs in animals. Some patients, especially older adults, are hospitalized with severe diarrhea and dehydration. Patients may be carriers of the bacterium for up to 1 year. Instruct those with Salmonella gastroenteritis and their contacts to wash their hands before meals and after defecating to avoid transmission of the organism. Staphylococcal infection. Staphylococcus is responsible for 25% of reported food poisoning outbreaks. It is found in meats and dairy products and can be transmitted by carriers of the organism. For staphylococcal food poisoning to occur, there must be contamination of food and a period of time, hours, during which the organisms multiply. This can take place during the slow cooling of the food after it is cooked. Symptoms of staphylococcal food poisoning include an abrupt onset of vomiting, abdominal cramping, and diarrhea. The person usually has symptoms 2 to 4 hours after ingesting the contaminated food. The patient is afebrile but weak. A diagnosis can be made when stool culture yields 100,000 enterotoxin-producing staphylococci. However, symptoms rarely last more than 24 hours, and people do not always seek medical attention. Antimicrobial drug therapy is not usually indicated unless an agent produces progressive systemic involvement. Parenteral fluids may be needed for dehydration. Table 66. Types of food poisoning. There's staphylococcal infection caused by contaminated meats and dairy products, can be transmitted by human carriers, causes abrupt onset of vomiting and diarrhea without fever. There's E. coli infection caused by meat contamination with animal feces, causes abrupt vomiting, diarrhea, abdominal cramping, and fever. Botulism, commonly associated with improperly canned foods, especially fruits and vegetables, nausea, vomiting, diarrhea, and weakness, progressing to paralysis, diplopia, dysphagia, and dysarthria. And salmonellosis, caused by contaminated food or drink, but can be transmitted by the fecal-oral route. Fever, nausea, vomiting, abdominal cramping, and diarrhea lasting 3 to 5 days. Escherichia coli infection. E. coli is increasingly becoming associated with food poisoning. Since 1992, a number of outbreaks of E. coli food poisoning have occurred in the United States, and an estimated 70,000 people are affected each year. Many strains of E. coli exist, and not all of them cause harm. However, some cause disease by making a substance called Shiga toxin. The bacteria that makes these substances are called Shiga toxin-producing E. coli, or STEC for short. The most commonly identified STEC in the United States is E. coli 0157 H7, sometimes called 0157. In 2007, prepackaged spinach processed in the United States was contaminated with this bacteria and caused hundreds of people to become ill. Enterohemorrhagic strains of E. coli, E. HEC, and STEC can cause serious complications, such as hemorrhagic colitis and hemolytic uremic syndrome. These problems affect older adults most often. The symptoms of STEC infections vary, but most people have severe abdominal cramping, vomiting, and diarrhea, often bloody. Treatment of the patient with E. coli food poisoning includes IV fluids and supportive therapy, possibly with antidiarrheal agents. Antibiotics are not effective. Chart 69 outlines best practices for preventing STEC infections. Botulism. Botulism is a paralytic disease resulting from ingestion of a toxin in food contaminated with Clostridium botulinum. Botulism occurs most often with home canned foods, particularly vegetables, fruits, condiments, and less commonly meat and fish. It can also occur in commercially prepared products and with products not adequately heated to destroy toxins before they are eaten. And rotten mayonnaise. Incubation is usually 18 to 36 hours. After this time, symptoms occur. Initial symptoms include diplopia or double vision, dysphagia, difficulty swallowing, and dysarthria, slurred speech. Illness may be mild or severe, with paralysis, respiratory failure, and death. Weakness can progress rapidly from the neck to the arms, chest, and legs. Paralytic ileus, severe constipation, and urinary retention can also occur. Nausea and vomiting and abdominal pain may occur before or after the onset of paralysis. Chart 69, Patient and Family Education Guide. Ways to prevent STEC, or E. coli infection. Wash your hands thoroughly after using the bathroom and after changing diapers and before preparing or eating food. Wash your hands after contact with any animals or their environments, e.g. at a zoo. Cook meats thoroughly to at least 160 to 170 internal temperature. Use a food thermometer to ensure doneness. Avoid raw milk, unpasteurized juices like fresh apple cider, and unpasteurized dairy products. Avoid swallowing when swimming. Prevent cross-contamination during food preparation by washing hands, counters, cutting boards, and utensils after they touch raw meat. STEC stands for Shiga toxin producing E. coli. The diagnosis is made, and we're talking about botulism again, back to the text. The diagnosis is made on the basis of the patient's history and a stool culture of C. botulinum. The blood may be positive for toxins. Treatment with trivalent botulism antitoxin, or ABE, is given as soon as the diagnosis is made if the patient is not hypersensitive to it. The physician may lavage the stomach to stop absorption of toxin. All patients are hospitalized to observe for and treat respiratory paralysis. Nothing is given orally until swallowing and respiratory difficulties pass. The patient prescribes IV fluids as needed. If respiratory paralysis occurs, intubation and mechanical ventilation are implemented. If ventilation can be maintained, the patient can survive and no neurologic deficits after the patient can survive with no neurologic deficits after the illness. To prevent botulism, teach patients the importance of discarding cans of food that are punctured or swollen or that have defective seals. Remind them to check for expiration dates and to not use any canned food that has expired. Containers for home canned foods must be sterilized by boiling for 20 minutes to destroy C. botulinum spores before canning. Human needs nursing care review. What might you notice if the patient has impaired digestion and inadequate nutrition as a result of inflammatory intestinal problems? Report of nausea, vomiting, report of epigastric or abdominal pain, diarrhea, sometimes bloody, elevated temperature, and weakness. What should you interpret, and how should you respond to a patient with impaired digestion and inadequate nutrition as a result of inflammatory intestinal problems? Perform and interpret focused physical assessment findings, including vital signs, complete pain assessment, skin turgor and mucous membrane dryness, abdominal assessment, current and previous weight, history of recent food intake, and history of recent travel. Respond by, you want to prevent pain and aspiration by sitting patient up, place IV catheter, large bore to replace fluids, provide privacy and assist with hygiene, provide rest, check laboratory values for hemoglobin and hematocrit, anemia, check serum electrolytes, dehydration, hypokalemia, give antidiarrheal drugs if prescribed, record intake and output, assist with ADLs and ambulation as needed. On what should you reflect? Continue to monitor for vomiting and diarrhea and changes in pain level. Think about what you need to document. Decide when you might need to call the healthcare provider or rapid response team for hospitalized patients. Determine what health, teaching, and community resources may be needed for this patient and family. Think about what you can do to help prevent complications of the health problem. Get ready for NCLEX examination. Key points. Review these key points for the NCLEX examination client needs category. Safe and effective care environment. Teach patients to use infection control measures to prevent transmission of gastroenteritis as stated in Chart 62. Collaborate with a CWOCN or ET nurse for ileostomy teaching and care. Collaborate with the case manager when planning for patient discharge. Health promotion and maintenance. Teach patients with chronic IBD to avoid GI stimulants such as alcohol and caffeine. Each patient's response to food differs. Teach patient how to provide ileostomy care, paying particular attention to skin care. The effluent has a high enzyme content that can easily cause severe skin excoriation. Instruct patients with diverticulosis about nutrition modifications such as avoiding nuts, foods with seeds, and GI stimulants. Teach patients with diverticulosis to eat a high-fiber diet. Diverticulitis requires a low-fiber diet. Psychosocial integrity. Be aware that all inflammatory bowel disease, acute and chronic, are very disruptive to one's daily routine. Chronic IBD requires a lifetime of modifications. Recognize that having an ileostomy impacts the patient's body image and self-esteem. Assess for coping strategies that the patient has previously used and identify personal support systems to assist in coping. Physiological integrity. Assess for the classic clinical manifestations of appendicitis, which include abdominal pain, nausea and vomiting, and abdominal tenderness upon palpation, McBurney's point. Some patients also have leukocytosis as well. Assess for the key features of peritonitis as listed in chart 61.1. Assess for signs and symptoms of dehydration in patients who have inflammatory bowel disease. Administer anti-diarrheal medication as prescribed to decrease stools and therefore prevent dehydration in patients with inflammatory bowel disease. Be aware that there are two major types of chronic inflammatory bowel disease, IBD. There's UC, ulcerative colitis, and Crohn's disease. Both have similarities but also have differences. See table 62. Recognize that perforation, rupture of the appendix requires prompt intervention and can result in peritonitis. Be alert for GI bleeding in the patient with chronic inflammatory bowel disease. Be aware that patients with Crohn's disease are at high risk for malnutrition as a result of an inability to absorb nutrients via the small intestine. And monitor for complications of UC as listed in table 64. Provide nursing interventions for patients with IBD as listed in chart 63. Administer 5-aminosalicylic acid drugs as prescribed, e.g. Pentasa and Dipentum, to decrease inflammation in patients with UC. Most of these same drugs are also used with Crohn's disease management. Administer corticosteroids and 6-mercaptopurine as prescribed with both UC and Crohn's disease. Infliximab or Remicade is used primarily for Crohn's, but may be useful for those with UC in selected cases. Observe for GI bleeding in patients with diverticular disease. Instruct patients with anorectal disorders to use sitz baths, bulk-forming agents, e.g. Metamucil, and stool softeners to decrease pain. Be aware that GI problems, including diarrhea, may also be caused by parasites and helminths. Okay, and that was Iggy 1316 to 1342, but yeah, it was all of chapter 60, patients with inflammatory intestinal issues.